research is a challenge, evidence-based policy is a challenge, and there is very little evidence-based policy specific, especially like, for example, the state I come from and I work in. Therefore, it becomes sometimes a lot of challenge for policy and for public administrators to understand what is working, is it actually working, is it actually having the impact that we think that this scheme or program or policy was framed towards addressing. And if not, what are the corrective steps that we could take, and what is the experience of the other similarly placed governments or similarly placed organizations from where we could draw some differences and use it for program implementation on the implementation side better. And I will say this with an example that for multiple schemes, for instance, we have a very ambitious traditional cash transfer scheme, and we have been struggling to find partner organizations to help us. I'm smiling at Dr. Deva when I discuss this, whoever I can catch hold of. So we're struggling to find partner institutions who can help us design and put in place a study which looks at our conditional cash transfer scheme for maternal and child care, tells us what are the implementation issues, what are the gaps, as well as also looks at the impact. Impact evaluation being the bread and butter of a million economists on the planet. It's really hard in the social sector to come out with actual robust evidence which says that yes, this is the scheme, this is the impact it had to bring women and children to the fold of formal healthcare, and this has had an impact, positive impact on their health, and therefore the government should increase or at least continue to do what it has been doing with us. Now, in this scenario, so the first, I'm starting out with a complaint. My complaint is that I find that the gap between academia and practice is actually still very wide. And I find that we need help in practice, the practitioners, to understand and from somebody who's looking at us from a hands-off perspective on how do they see us to be working and how can we become better in what we're doing by doing a few things which are, say, the low-hanging fruit, or by doing something more, which might be much more systemic in nature, which might be more institutional, strengthening capacity, which will necessarily be not short-term fixes, but will require much more in-depth work and rejigging. Now, so therefore, we have, for example, I have from AIMS Bhopal, Dr. Shastri is here. We have community medicine departments in various countries. Again, they mean well. We've given them some studies. But I find that we are not able to get the study design which they can sort of go out and their research will go out in the field and come back to us. Now, so for us, research has to be on both sides. It has to be on the implementation side, operational side, as well as on the user's perspective, the consumer or the beneficiary perspective of how it's impacting, social impacts. Social impact is harder. Operational issues is simply is a little bit slightly simpler. However, there are more challenges, and that's where I think governments. I would think I can say for myself that my government and my team would definitely need to do a lot of work, and we are very happy to announce policy to anybody who wants to come and tie up with us and help us. This is said we perhaps मुझे इसको ना tie up with us and help us in setting up. देखता हूँ अगर ऐसे हो गया. Here again is a very important point I would like to make. partner hospitals and speak to them and tell them the seen by a third party when are very useful to the to the implementing agency to understand where can checks be applied, where can where can correctional efforts happen. And then, of course, the larger agenda is that there have to be epidemiological sort of database has to be developed, and we need to learn from the more advanced economies which have used market-based, health systems, health insurance and health assurance systems, and how the market is now, after decades of research, is now maturing into realizing that it is better to invest in promotive and preventive healthcare, and rather than reimbursing claims, and how we need to make an early beginning from, instead of going through the learning curves ourselves, from these learnings which can be derived from these much more market-based economies and their healthcare systems. So I think from my side, these are the few thoughts that I have, and I'm sure people who are much more into research on a daily basis will be able to articulate this better. Thank you.
Thank you, and I think these are very pertinent points because even though if a researcher is doing a research, if nobody is able to make use of that research, then it goes only to the journals and it doesn't help other than the researcher to feel happy about it. But if it goes into the policy making, and that's where I think it's very important both ways, that the researcher should do research which is actually useful for the government, for the policy makers and all, not all the research, but at least many of that, and the government should be open enough to take it. And that's where I think what you mentioned, that your government is very open to actually take these suggestions. In fact, you are actively looking for people to partner with you. So I think that is something which is a great news. And when you talked about data, it reminded me of a quotation. It says that some people use research and data as a drunken man uses a lamppost, not for illumination but for support. So we have to move away from that, and we have to actually use the data for illuminating ourselves, and that's where we are. So thanks a lot. And then I will since you have to leave, so you are free to leave whenever you want. Now we'll move ahead with the session. So you wanted to say something?
Yes, please.
Only 1 minute about your first point, that the relationship between research community and government. I just want to share with you a new good news from our state, that our state government of Tamil Nadu has established, signed an MOU with our institute to establish the state health resource system in our institute.
Excellent.
So basically the MOU talks about the kind of thing that we will all be thinking about here. Just 3 months old MOU.
Excellent. So we do have a state health resource center in Madhya Pradesh, and they have been conducting studies, and so we've been actively pursuing IFMR Chennai because they've been doing a lot of social sector research formally. Now that I've met Dr. Muralidharan, I'm going to be actively pursuing him as well. So
it's located in our campus.
Wonderful. Wonderful. Excellent.
I think it's good to start a session on this kind of good news, and often Tamil Nadu and Kerala and many of these states shows the way for many things. So thank you. Now basically let's move ahead, and I will request Sharmishta from JZ to give a brief presentation on the study. I think the presentation must be loaded, so you can just take this and okay, somebody will change this. You can change from this also. So basically what is being done by GIZ, that they did a baseline before start of the scheme, which was also helpful to see that before start at least what was the level of out-of-pocket expenditure and things like that. But at the same time, since the mandate that time was to evaluate also RSPY, what was happening at that time, so it also shows that what had happened during RSPY, and then also this study acted as a baseline, and after 1 year, another round of study will be done, which is now. So
website of Beneficiaries?
It's not there right now. It's not on the website. So, yes.
Yeah, just to quickly begin.
Mic on.
Good afternoon, everyone. I will quickly present this.
Can you summarize the major points so that we can write in the more slides?
Yeah, I will just briefly talk about the conceptual framework and summarize. Like the conceptual framework behind conducting the GIZ study. So we have looked at both supply and demand side, which is actually influencing the access to healthcare. And so primary objectives, what we have done is we have done an evaluation of PMJ, which is serving as a baseline for Ayushman Bharat, PMJ. And we have done an evaluation of RSBY, which is serving as a baseline for ABPMJ. And looking at the supply side, there is to assess the impact of PMJ on quality of service delivery and also to understand the implementation experience of the service providers. We have done a study on that, and also to assess the impact of PMJ on insurance awareness, coverage and health service utilization as well as financial protection. And overall cross-cutting agenda has been gender focus in all our research. So quickly telling that what are the research which is completed and what are the research which are ongoing. So we have already completed in 2018 evaluating the performance of impact of RSBY, which I was talking about, and also the hospital study on quality of care and implementation experience. So, and then our ongoing studies are, we are currently conducting a literature review, which is to map the existing evidence gap in South Asia on health insurance, as well as we are doing a process documentation, which is to understand the transition which states are doing now from RSBY or state health insurance to PMJ. And then we also have a follow-on study of the RSBY, which is a household study, and then a hospital study, which is also a follow-on study. So most of the study design, what we follow is concurrent triangulation mixed method design, like basically mixed method design what we are doing in most of these studies. And the study areas are Uttar Pradesh, Bihar. So we had taken for RSBY, we had taken Uttar Pradesh and Bihar as a baseline for our concurrent studies. And the other states are Gujarat, Chhattisgarh, Tamil Nadu, Karnataka, as well as northeastern state, Meghalaya. And for the hospital study, we had conducted the study across 3 states, that's Gujarat, Chhattisgarh and Bihar. Again, as a control. Yeah, so coming to the household survey, which we conducted in 2018. So we had conducted a household survey across the 7 states, and our sample size was around 14,140. And so we had a intervention.
Maybe can you do that? Let me just take few slides from here. Thanks, Ramesh. I'll just take few slides from here. So basically, you can see here socio-demographic part that interestingly, people who had less schooling were more insured more. So that was counterintuitive, but at the same time, also people who were more learned, they thought that these schemes doesn't work, and they had this misconception about the scheme, so they didn't enroll in the scheme. But otherwise, it's quite normal. What is coming basically here. Then awareness part is very interesting. What we found that in most of the people who were being made aware were not by radio, newspaper, or leaflet and brochure and things like that. It was more through friends and neighbor and through panchayat mostly and Asha worker. These 3 were coming as the main thing with the people who were insured, they were being made aware about only these things, which means that either we do it better if we are using others, or otherwise we don't do it. We don't waste money on those things and more improve where people are actually being targeted. PMJ was very early, it was August before launch of the scheme, but still about PMJ from where people knew that time there was advertisement in the newspaper, Asha worker did a drive, and then Panchayat and through friends and neighbor. Again, radio had reach only in one state, but otherwise things didn't work. And since Chhattisgarh started the pilot from 15th of August, that is why Chhattisgarh there was some 20-26% were aware about the scheme. In other states it was very less, but it's before the launch. So the next round we'll see what is happening actually. Out of pocket again we wanted to see what is happening. So it's very interesting to see that in most of the states people who are insured, they are spending a bit less. Like Chhattisgarh, if you see median both, it's almost median if you see is 10,000 for the non-insured and 2,500 for insured. But still people are spending. It's not that people are not spending. So, and across the states you will see that there is this, and Tamil Nadu in fact, the effect is very less, what we found. So we have to go more into the reason, but the interesting thing was that it was less, but still it was quite a lot. So that is something which is coming out.
The difference is not significant.
Not significant in few states. Some states significant, in some states it's force significant, 90%. And this is another thing which we just wanted to take a perspective, that what people say, that do they think their out-of-pocket has come down because of the scheme. So that's where in Tamil Nadu only 28% people said, but Meghalaya 75% people said that, no, it has helped in reduction. But that didn't support the data. This was more of a perception. One thing which was very interesting, we just wanted to see something on gender. And what we found here, that the people who were in the families which were covered, so women found that this kind of scheme helped them in taking decision on their own in comparison to people who were not covered in the scheme. So there was some kind of, you can say, women empowerment kind of thing was happening, but we'll have to dig deep into it. But it was something which was very interesting what we found. And even the access, women felt that they have better access to healthcare when they are covered under the scheme vis-a-vis when they are not covered. So basically recommendations are simple as which came last year actually, that remove the family size, enrollment process should be much more simpler, increase the cover. A lot of things are already part of PMJ design, and more hospitals need to be empaneled at the block level. So it's not that they are something which was very new, but it is again supported by the research which is coming out. Another thing which was done on the hospital part, which was the the study were done on the empanelment of hospital. So of course, they went there, they collected a lot of data. So basically on the quality, they found, what they found that there was no push from insurance to push for quality. Hospital did it on their own, then it is fine. Many of them in Gujarat, for example, accredited themselves in under NABH. Patient satisfaction was, they were collecting patient satisfaction feedback at the time of discharge and evaluating it and doing it, but again it was there in Gujarat, in Bihar it was not so much. So it depends also on the state, and as you know there's a lot of variation. And so basically what we found, that gaps and challenges, that low package rate was a major thing which had come from most of the states. And then claim delay, claim settlement delay, missing claim information, these kind of things were coming. Then again sometime they were saying that beneficiary talks rudely or behave rudely with the hospital, and these kind of things were coming up. People will come and say, I'm covered, but they are not covered. So these kind of things were there. And money was taking a lot of time to reach the hospital. This was one of the main challenge which was coming. So I think, so this is recommendation. I will not go into that. So this is what basically the main things which had come from this study. So the idea was that just very briefly share what we will do, that we will share this presentation with all the members sitting here. So it's not that you need to write down things, you will get the slide. But the idea was that very quickly we share with you. Now I will request Henk to share, because WHO has very recently finished few studies which have been very critical and which have provided very interesting insights to NHA. So Henk, please, thank you.
Thank you very much. If you don't mind, I'll come ready to say we have very nice posters of this, the tree research what has been done. But if you don't mind, I would like one moment just to sit back. First of all, I'm very pleased to be over here. And look, let's sit back for one moment. Many things have happened over the last years, and when the late Minister of Finance, Arun Jaitley, on the 1st of February 2018, when he announced Ayushman Bharat, I think it was quite something, and I think we've all felt that health became on the agenda. And there were two components of it, the PMJ and the health and wellness centers. And one of the points that I'm trying to make is look, we can do research, but at the end, I don't know if you saw the session, what was also the plenary session was held over here. Both Dr. Vinod Paul and Peter Sudam making very clearly a point. If you look at health, don't look at it in isolation. And like also, Nissan, what you just mentioned yourself, it is not in isolation. We have public health over there, we have a TB program, Mission Entrepreneurs over there, we have the Health and Wellness Center, and then we have this part that provides financial protection. But what is very important, and then I'm also reflecting on my experience in working in other countries. If you're in a country like India, where there is now actually there's a major reform going on, something big is happening, health is getting on the agenda, then it's very important to sit down in the beginning and say what are actually our objectives? Our objectives is a better health outcome. But the PMJ, for sure, we want to provide higher financial protection, that people have access to it. We want to make sure there's quality care, there's improved satisfaction. And these things are very important to keep in mind for the whole period that we are now looking at the health sector. India, a special challenge, what you also have is diversity and the capacities what you have over the various states. Now, our argument, what we would like to have, is that you need to have an overall monitoring and evaluation framework for the whole health sector. In the past, we called it Health Sector Performance Framework, in which you have all these major objectives you have there, and at the end you come back to some clear indicators, etc. And why is that so important? It is always important because, look, sometimes you do research and you don't even know, have you covered the whole map? Are there big bits and pieces that still are not mapped? And again, PMJ on its own does certain things, but I think if you sit one step higher, if you look at the population part and the Prime Minister, etc., and the Health Minister, then you would like to see if the overall health sector is improving. So we strongly suggest that you need to have an overall health sector performance framework, which is covering PMJ specific issues, what is specific for the Health and Wellness Center, but also what is for the whole health sector, including also in public health. Now, there is also something else from myself. I worked also as a Director of Health Sector Development in the Western Pacific region, next to here. And one of the challenges what we had in countries is that the capacity to do actually good health system research. There is capacity, also in India, you already see quite a lot of good research going on, but actually the routine part in good health system research is really an issue where we really believe that it's important at this stage that you need to start building capacities in this area. But there's also something true from what is research? Is research only when getting out over there and doing household survey and going to a hospital? Actually, the research starts already with your own information system. If your information system is good, then you can get a lot out of the information system itself. I would like to reflect also the social health insurance in South Korea. They have a system what is called HIRA. It's Health Insurance Review Assessment. They do the quality control afterwards. How can they do? Because they have a system where there is sufficient detail where you can follow the patient, you can follow the individual provider, not only the hospital or the clinic where it happened, and you can see how much was prescribed, etc., etc. And they have, for instance, a system that afterwards they can write to a provider and say, why is your average antibiotics is more than 2 on every prescription? If you continue like this, you're out of our system. So I would like to make a point, you need also to come with an information system which is granular enough that you can do certain things. And I would strongly advise that you need to look into, and especially quality control, that would be very important. Then you start creating your NICE or your HIRA already with a very good information system. I'm very encouraged by what's happening out in the National Digital Health Blueprint, and also that the PMJ is working very closely with them and is also moving towards more granular parts. Important over there is that you need to have agreement on the coding of the patients, etc., and the coding of the providers, etc. But a granular system is important. But let's return for one moment to building this health system research capacity. We have countries like in Thailand and in Mexico, they have specific bodies who are actually looking at overall sector. And they are slightly independent. They are linked. They are part of the health. In the Ministry of Health, it's like the IHIPP, the International Health Policy Program in Thailand, is part of the Ministry of Health. But this is also has its own room to maneuver as well. In Mexico, we have something similar too. We do believe that it's important that at least you have at least a place within the government that you create capacities to focus on this part. Now, but what is also important, do not only think that you talk about then government capacities. It's actually mobilizing universities. And if you see what the research what we have been able to do, we mobilized the universities. Is it from Goa? If it's from Madras? And I think we also worked with Kandinagar. Now, that's very important. There is a lot of capacities out over there, but then you need to engage them. What is important, I think, was already said, and Nishan, you said already very clearly from the example, from the most important part from research and research questions, it needs to start from the policymakers themselves. If you think that if you do just research, that a policymaker might be interested while you're getting your PhD, bad luck. 95% of the time they will not be interested because it didn't relate to what they were wanting. Yeah, you have your nice paper in the Lancet or whatever, but you need to start with engagement of the policymakers. And here I would like to give also a lot of praise to PMJ. And by the way, I'd just like to reflect what Inder Bhushan said to me before he started. It was in April last year. They say, Henk, can you help us to get started? Can you help us to set up a monitoring and evaluation framework? And the third one, he said, please keep on telling what we should be doing. Now, I really admire that spirit, and that spirit is still there. But I would like now also to suggest for the PMJ, but also for the overall health sector, that you need to start coming with an overall health sector performance framework in order to move forward on this. I think it is, I didn't realize, but I don't know if you expect me to say something about the three researchers, what we did, or that I can just ask the people who are sitting over here to do it.
The posters are there, but if you want to share...
Summarize.
Okay, I will do it in a summarized way, but again, I think that it will not reflect from all the work that was over there. Now, there are a few things that we looked into, and again, that it came from the questions from the people who are working in the PMJ and the people in the field. And one was around awareness, and I think you also had already something over there. This was, by the way, done by the India Institute of Technology from Madras, and actually, Professor, you're sitting over there, so I barely dare to say anything while you're over there. But one thing was keep it very short. There were three states where they went to, in Bihar, Haryana, and in Tamil Nadu. Now, we all know who needs most of the services. That's in Bihar, number one. Perhaps Haryana, but Tamil Nadu, I think the health status, if you look at the health status from Niti York, is a lot better. However, in Bihar, the awareness about PMJ was less than 10%. In Haryana was 12 to 13%. And in Tamil Nadu was nearly 60%. Now, that is something. Where they needed it most, they knew the least. And I think the PMJ has already been taking it up very clearly, and that was one major conclusion. But it was also very interesting that while the awareness in rural area was lower in urban areas in Bihar and Haryana, in Tamil Nadu it was actually the reverse. They were more aware in the rural areas about PMJ. So I think there's something in Tamil Nadu that we need to learn, how it was being able to spread. One thing was also very clear from that study was that the beneficiaries were very price sensitive. At a certain moment, if they need to get a card and they had to pay 30 rupees, then many of them did not pick up the card. Something to keep in mind. So there was a second study was also done, and that looked on the processes within the hospital. From if I enter a hospital, and how do I get service, how do I get my card, etc. And one of the major things came up over there that in those places, and he looked at Gujarat and Madhya Pradesh, those places who had a more qualified person who understood the health sector itself, either way a background as a nurse or an MHA, it went far much faster. It went far much quicker. People understood. People knew what to do, etc. And that was a very important part. I think the Secretary of Health already mentioned one thing, that they did the high incidence of out-of-pocket expenditure was one of the things that also was there. Then there was one very interesting part was also done by the Goa Institute of Management, and Dr. Kea is sitting also over here as one of the lead researchers. And they started looking at two models of implementation. One is the trust model and one is the insurance. Very interesting. Now, that was still perhaps at the end, there was one conclusion, perhaps it was a little bit too early, but the initial part was saying look, while the insurance, they had some increased capacities in doing things, but if you look at some of the performance from the trust model, they were actually more very vigilant. They were very precise in what to do and follow up, etc. Very encouraging to see that. If you look, of course, with the cost part of the insurance, with the current rates, I think insurance was a bit more expensive. But it was also envisaged if later on you would get more clients, that perhaps per person it would perhaps end up a little bit more positive. An interesting observation, what I also made, but it was not actually covering, they did also very clearly geographical mapping from those hospitals who were impaneled and who were not impaneled. And although it was not part of the research, but it came also up from, there were actually geographically, there were some gaps. And this is something which I think needs to be looked into also very clearly. But again, I do not do virtue to all the studies, but I'm happy that the colleagues are sitting over here. To end my story, to go back to 3 or 4 issues which I would like then to conclude about, that we do believe that it is important to come up with an overall health sector performance framework. We do think that you need to have teams within the ministry and within PMJ to look at it. But you need also to have to build up the health system research capacity within the country. And indeed, I think there's a bit of discussion who all should be involved in this one. But to start off, have an overall health sector performance framework in order not to get lost and only be happy from what you see. Perhaps there's things that you should have also investigated, etc. Thank you very much.
Thank you, Henk. And I think thanks for reiterating again that the overall health sector performance framework is very important, and to understand that PMJ is part of a piece of a puzzle. It's not the whole puzzle in itself. And I think that is very important to understand, and sometimes people who are too close to it miss that point. So thanks a lot. So maybe I'll come to Mr. Rajiv Sarandan now, because in his various hats and with the existing hat now which you have, what do you see should be the top research areas for PMJ in the next 1 year or 3 year, what you will say, and what kind of things it should do to actually focus on those areas?
Thank you, Nishant. Based on the various hats I've been wearing, if you'll promise me that you won't say this outside, I'll tell you a secret.
Okay, let's leave it.
Do I have your word? Okay, you can, but don't attribute to me. We had the impression that PMJY is a finished product. That's not true. It's going to take years. Germany took 40 years to stabilize. Japan took what, 50? To stabilize. To imagine for a moment that PMJY in 1 year has solved all the puzzles is, we are Indians, of course, but it's a little too much to expect. So the secret is lots of very uncomfortable questions will have to be raised and answered and not brushed under the carpet if PMJY is ever to grow. And that's a humility that we need to develop as we go along. Now, I'll just talk about the latest hat that I'm wearing, which is heading an organization which works in the area of implementation research and health systems. It's slightly different from the retrospective studies that you had. It's slightly different from the data analysis that you had. We're looking at the some of the key system bundles that drive health sector. There are issues like around financing, about provisioning, about quality, about regulation, and so on. So what we are trying to do is a little more ambitious, and the methodology is a little different from what other organizations do, and therefore our time frame is also going to be much longer, and the probability of failure is also going to be high. The advantage is that even if you fail, that's a success. Now, some of the areas that we've decided to focus on are basically around 3 areas. One is, we know that PMJY covers only the hospitalization expenses, and Henk and all the others who have been publishing in the area of health have always told us the basis of good health is what? Good health system is? Come on, your students, tell me. Primary care. And where is primary care in this whole thing? So that is the question that we'd like to raise. How do we ensure that all the PMJY beneficiaries have access to primary care? Now, once that question is raised, then it kind of breaks up into different subcomponents. From a research point of view, the end result would be, does good primary care lead to reduction in claims, reduction in out-of-pocket expenditure, and good quality care? That is for much later. Now, this question of how do you provide primary care will again get broken up into different subcomponents. One is, how will it be financed? Of course, if we have somebody from MOHFW, maybe 3 months before even I would have given the answer. Primary care is provided by government. We don't need to ask anything about it. Unfortunately, the National Sample Survey, the 71st round, which has been done by the government themselves, does not support that claim. Not more than, Murli, 35%? Government provision of primary care would be 35, 40 is provided. What happens to the rest? This is independent of PMJY, but in the context of PMJY also, that's important. Here we are taking responsibility for a certain set of people and knowing fully well that primary care has to be provided to them. What are the most efficient ways in which this can be provided? One, do we bundle the primary care provision with the benefit package that you have? If so, how is that going to get financed? For the beneficiaries of PMJY, will the NHA pay for the primary care part? That's question number one. Two, if government does not pay, how will it get paid? Are the beneficiaries willing to pay? If so, how much are they willing to pay? That is the second question. Third one is, how is it going to get provided? Nishant talked about supply side constraint. If government hospitals, even the state that I originally come from, which is Kerala, which has got one of the best health systems in the state, government system is bursting at the seams. It's unlike in other places, its quality is considered pretty good, but the capacity is just not available to handle the load. If we are going to ensure primary care for everybody, will be provided always by government? Is government capable of doing that? I would think not. Then, what is alternate method of provision? Shall we work with the individual practitioners, with group practices, and so on? So how will primary care get provided? How will it get financed? And how will it get organized? Will it get bundled with the PMJY product or not? And the outcome question that I'm very keen to find out, and I have not got the answer, is: does good quality primary care reduce utilization of secondary and tertiary care? So, and also does it lead to reduction of out-of-pocket expenditure? That is the first part. Second one is, PMJY addresses a certain segment of the population, the SECC population at the base level. Many states have gone beyond that, but that is looking at all these. All these are looking at the poor alone. And again, I think it's one of Henk's organization's publication which says that healthcare for the poor will be what, Henk?
Poor.
Poor healthcare. Yeah.
Health service for the poor.
Yeah. Health service, just for the poor will be poor healthcare. But more than that, we know from some of the recent studies conducted that at least in where I come from, one of the major elements that pushes a non-poor family into poverty is paying for healthcare, which means that if you are addressing even the basic part of financial protection, unless you take care of not only the poor but anyone other than the super rich, we are not meeting the objectives of PMJY, which is financial protection. Now, if that raises a whole host of questions, given government's current fiscal stress, if government can afford to pay for this for everybody, wonderful. That's what Thailand did. Hopefully, if that happens, that will be the best way to go ahead. But let's be realistic. It looks, from where I stand, it looks highly unlikely. Then, what is the method of financing this care? One of the interesting things when you look at the NSSO 71st round is that even in states where the propensity to consume healthcare is fairly low, the out-of-pocket expenditure by people consuming healthcare is not insignificant. So, at a common sense level, if a whole population is paying a certain quantity of money for consuming healthcare, it makes sense to pool that amount and come up with a prepayment mechanism by which out-of-pocket expenditure is solved, is reduced. Now, the unresearchable question is that why are we not doing it? But the researchable question would be, how much would that cost? At a simplistic level, the total expenditure by the population divided by the total population should give you the per capita outflow. But it's also possible that with unified purchasing, you will be able to negotiate better rates. So, how much will be needed is one question. Two, more importantly, a lot of this is behavioral, how much will people be willing to pay? A very interesting question that we would like to ask. Third question is, if we know something is right and if we know that people may not be willing to consume it, then the question is what nudges can you use to persuade people to use this? Hopefully, within a year, our organization should be able to launch a few studies that looks at this, and then maybe 2 years down the line we come back to you and give you what we have learned. And it's again a lot of questions around structuring this. Now the other side is most of these consumption has been done based on fee for service. That again is not a very good method of provide a payment mechanism. Are physicians in India willing to take a different mode of provision, like capitation, for instance? Most of the countries have moved to capitation and other more advanced modes of care. Can we move to that? Or you want to get more ambitious? Is it possible to pay people based on performance? So that is the other question that we still don't have the courage to ask, but hopefully someday we'll develop the courage and start asking that question. The third one is even more interesting. Thailand, if you look at the way they have moved the government health system, they have moved away from line budget into the global budget and outcome-based financing. I hope there is no one from government here. Can we move providers in India, the government providers in India, away from line budgeting, line budgets into a more, more efficient system of doing? Again, at this point, we don't have the courage to ask that question, but what we hope to do is use the show it to the hospitals that if you do your provision well, and if you get your PMJ beneficiaries, your ESI beneficiaries, and you see the amount of money that you make, can you take away at least part of your budget into this and free that hospital budget for something else? Maybe a few years down the line, we'll have the courage to ask that question also. Now, we come to the third question that we'd love to ask. Third. Okay, the third question is something that has fascinated me in the Affordable Care Act. Lots of things interesting about the Affordable Care Act. But what I found interesting was the way they have been able to index payments based on quality. How can we use PMJY to incentivize quality? Again, a very, very difficult question. What constitutes quality? How is it going to be measured? How will you enforce it and so on? But I think for PMJY to survive, because many of the studies have shown that where payment was made voluntary, and not only in India, it happened in Vietnam, it happened in other countries, where payment was made voluntary, what the two factors constrain people taking it up. One is the lack of information. The second one was lack of trust of quality. So, if PMJY has to become the framework for healthcare in this country, we have to move away from numbers alone. We have to move away from money alone and look at quality. And which would mean what is quality? It's the whole questions about how to measure and all. And at some stage, move both government and private providers into a payment that is indexed on quality. I think it will work. That's a question again that we would like to get research. That's three. Thank you.
Thank you, Rajivji. And I think these three are actually not three. There are too many things hidden behind these three. So you have given us a set of questions actually which can be very helpful for not only for NHA but even for the researchers to come out with proposals also to what to work on. And I think all of them are very critical on some of them. Some work has started, like NHA is doing some at least input quality based grading they have started come out with, but still processes and output and outcome, that's a long way to go. But I think that still it's an early beginning, and I think we have been trying to do some things on this. Now on my right side, Dr. Murli Dharan is here from IT Madras. So from your perspective, Murli, when you look at a scheme like PMJ and you look at the research which needs to be done, now there could be done research based on primary data collection, which is not always fast and cheap. It's always costly and it takes time. And another is that there is a lot of secondary data also being generated by PMJ. So what kind of data you see would help the researchers, even for NHA, to be made available, for research, and what kind of data will not be available and should be collected from the field for the topics, like for some topics which Rajiv mentioned and other things?
Good afternoon. Actually, what we do as a group in our institute last 10 years, we also define it as implementation research. We work very closely with the government. The problem statements are also discussed with the government and is to be seen as useful by the government before we embark. So I would like to propose three specific, to illustrate as an answer to your question. I have come with three problem statements. These statements have been discussed with Dr. Silva, who is in another room here, and his team just last week as a preparation to this. The problem statement and the method, and how would it help, how the results of the studies can be fed into the implementing mechanisms that are already in place to strengthen the implementation. One issue, the problem statement of the problem one, is that because in states like Tamil Nadu, where many states have had CM schemes for about 7-8 years, this would be useful as we see. Across districts, there is considerable variation in the utilization of specifically services by NCD patients. If you assume broadly across districts, let's say the cervical cancer prevalence is more or less same, but the utilization by the beneficiaries varies substantially, and we have a 10-year data set, and any scheme that has run for about 5 years would be able to use the secondary database and with specific services in mind, and even the sampling has to be purposive because you are concerned about certain services and in certain regions and even by hospitals. First do an analysis of that and then take a sample of those people and do a household analysis. So it's both primary and secondary data, and the primary data from the household will tell us why some people, we know the households that have used, so we know why they've used, but we need to also figure out households who did not use, who were also potentially beneficiaries. So that requires a very careful design, but we would like to propose this because the results of which can directly be fed back into the system, and they would like to ensure that those who are not using it but are eligible could be brought under this scheme. That's one. The second is almost everyone is concerned. Statement of the problem is that about the high out-of-pocket expenditure among those who have availed as beneficiaries. So either it's an overbilling. So there is a mechanism to follow up through the grievance mechanism, the squad, but again through a household survey. Among those who have availed the services in the last 3 to 6 months, where the memory is pretty fresh, we could do as a regular household analysis and feed literally the details of the households that have spent on many through overbilling into the system, and they could take it up as part of their own investigation and follow up and address the grievances of those people. So it's again primary and secondary. The third one actually came out of the survey that we did. In Tamil Nadu, those who were beneficiaries under PMJ were already part of the Chief Minister scheme, so they were merged and the letters were sent. But we found through this, 15% of those who received the letter had still not got the CM's card. And the CM scheme has been there for nearly 10 years. So, but we know from the database you have whether Mr. X is both here, and who are those 15%. And we need again a survey of those people as to why they have not been. The reason is that if and when they needed hospital services, they would otherwise end up spending out of pocket. So they need to be targeted and brought in. Very focused 3 illustrations, all of which will require definitely primary survey or some amount of primary survey in order to use and which requires use of the already available data. So if I had about a year's time, I think 6 to 8 months time, I mean these things can be reasonably implemented, and we can go in phases. Do not try to cover all the sticks. Some of the statements I made maybe can be attempted in other states as well. I'll stop here.
Thank you. I think these 3 are very precise, very focused research statements. And of course, I think many of them will be valid in any state. If we talk about out-of-pocket, if we talk about access, it's valid in any state. Just that maybe the formulation will change a bit, but otherwise it will be valid. And that's where I think the importance of primary data also comes very strongly, because if you want to know about out-of-pocket, you can't get from the secondary data. You have to collect some primary data, but a lot of things you can still get from the secondary data itself, which is the utilization data, the pattern, all these things. And especially once the scheme is getting old, you will get time series data, which can then help in seeing the patterns and everything. So I want to apologize in advance that we could not have an interactive session, because we really wanted to do, but as you would have noticed, the inaugural session. No, I will come. Yes, but I'm saying, but you saw the inaugural session. It went much longer than what we expected, and then it spilled over. But still, we will have at least few questions, 3 to 4 questions from the audience, and then we will close the session, because then the next parallel session will start. So, if anybody from the audience, if you have anything, yes, ma'am, please, you, and then Deva.
The question is to Dr. Sadananda. You said that you are looking into the question that does the good primary care reduce the utilization of secondary care. That is something that we public health specialists would always want to know and have been advocating, but have really failed to demonstrate it. So it would be very interesting to know exactly what is in your mind to demonstrate it.
Sure. Deva?
This is actually not a question. It's this thing to the researchers community here. See, working 30 years in health in this field, one major issue which I find in our country is that the government launches schemes, puts in very good guidelines, and then expects that it is being rolled out very perfectly on the ground. And you and I know that it is not so. So I think our focus, especially as Rajiv said, if we want to make PMJ really grow and become the national health insurance for the country, I think instead of doing a before-after study or doing one series of cross-sectional studies and publishing it, if we can link up with the governments to actually do implementation research, help the governments understand what is happening on the ground. It may be about awareness, it may be about out-of-pocket being charged by the hospitals, whatever. Take a small thing and run it through till you have solved that problem, but work with the government, not as something that you're saying, trying to find fault with the government and saying, listen, hey, there's out of pocket here. It's not, that should not be the spirit. Spirit is, if there's an out of pocket payment, how can I, as a researcher, work with the government to solve that problem? I think that sort of implementation research should be the focus if you want.
Yeah, thanks. I heard a lot about the research and primary data. But I was thinking when this was being discussed that there are many things, so many questions, research questions, which can be answered through available secondary data. And we have like NSSO data which can answer at least a little dated, but still it can answer some question. But I was wondering that many of the state-specific scheme or even PMJY has a claim data, and probably the availability of claim data to the researchers for analysis can answer many of the questions, or at least it can triangulate what they collect through primary data and secondary data. So I did not hear about that. That's what I was wondering how this data systematic mechanism can be developed, that data is available in public domain and then people can analyze. Second quick comment or question is, again, there is a need for interlinkage of this research which is coming from particular vertical or domain to a broader health sector research where researchers working in one particular area also are aware about what is happening in other area and work together. So maybe institutionalizing the research capacity in the country. Thanks.
Thank you. And just one last comment maybe from this side, anybody? So, yes, please.
Just wanted to just give my impression because I am a hospital administrator right now, although a doctor. So when I see that the things are to be implemented, we talk about the beneficiaries and who could not roll out or who knows down the line. But we forget mainly the healthcare providers. We presume that they would be knowing, and what we are facing is that beneficiary would know definitely that I have to go and get healthcare. But there are a lot of myths and a lot of problems associated at the level of primary, secondary, and tertiary. So when we are launching or when we are putting in some kind of a research effort, I think in that area also that could be a very good area of research, and that would really help this scheme to be launched in a better way.
Thanks a lot. I see two hands and now in two minds because we have to start another session. Is it a comment or a question?
Comment.
1 minute, very quickly, and then you.
Okay, so now there is focus on research, but I because I come from Arunachal Pradesh, a very large state with least population, with very hard topography. So considering and based on the funding that is based on population. So I just wanted to, nobody's talking about health equity in terms we have, say, we don't have supply side. Now if we augment this demand side, even if we have a good demand side of the healthcare system, we don't have the supply side. So most of even now, if we do, we'll have to refer a patient to places where, so I think this health equity in terms of provisioning of healthcare services to be also a focused area.
Very important. Yes, please.
Sir, I'm Dr. Sunil Kadyan. Sir, this is regarding the perspective of healthcare providers. Sir, when it came to package system in Ayushman Bharat, they are at a very lower side when it comes to pricing. Now, what is happening in the hospitals, especially the network hospital, that even the different TPAs and the standalone health insurance companies are negotiating as they are comparing it with the Ayushman Bharat packages also. So can we have some research from that perspective also?
It's a nice way to put it.
Thank you, ma'am, for that question. Actually, my interest predates this. One of the organizations that I really admire is the Kaiser Permanente. They have integrated care. So I had gone to the Kaiser Permanente head office to see if I could have access to this information. And Kaiser, as you know, is not very free with the information. But the impression I had was that even their approach did not show that good primary care actually reduces cost, but improves quality. So which is why we're framing this two questions. If it doesn't reduce cost but improves quality, it's worth the money. So the design is not very difficult, when you can have controlled cohorts and so on. But if you're looking at whether quality has gone up, that's going to be the difficult question to answer. So hopefully, we should be able to work around that.
Thank you.
Yeah, I think very briefly, and on this question also from ICMR, I do think that there are issues on the health and wellness centers around the demand side. And I think some research we also supporting from WHO side, but I really think there is a bit of an issue from. Let us look at it. The health and wellness centers of today were the center before. When you went over there, most likely there was no one there. If there was somebody there, he or she might not have been good. If he or she might have been good, there might not have been any drugs. So if you have gone to that place before, even when it has become a health and wellness center, which is for sure in a far much better shape, it might take some time before you overcome. And you have to go to the trust. So I think, again, awareness and the trust part, I think that's an issue. And I think there's one part I think we're supporting now as well. I think on the role of the implementation, is absolutely what you say from, this is what I mean, the health, you need to have an overall system and framework. And then within it, you routinely do. Not only when somebody is ready for it, or when there's money, I think it is a routine part what needs to come back. Healthcare providers are a very important part of the health sector reform. At the end, if the providers are not with you, it's very difficult to see things through. So very, very important. But when also on the equity part, I think this is an issue which I was only alluding to. If you look at the empanelment of the hospitals of today, not bad, but also not good yet. If you look at the equity part, there are gaps. There are gaps in quality, because some of the private sector hospitals are not enrolling as expected, and we still, geographically, there are some gaps. Now, here's also something very important. We strongly believe, and I think India is moving towards it, now is a scheme for 100 million families, 500 million people. We strongly believe that, like the late Arun Jaitley was saying, we hope that what we're in now, but also Vinod Paul was saying this morning, that this is the first step towards universal health coverage, meaning universal, that at the end all Indians would be there. If that's the case, the empanelment of the hospitals might go a bit better. The empanelment of the hospitals is not going well because those ones who are not empaneling didn't get a penny from the poorer people. They might at a certain moment start engaging or re-engaging at the moment that it is clear that the scheme will not stop with 500 million.
Thank you. Thanks, Hank, and thanks to all the comments and questions. And I think, Deva, the implementation research part which you talked about, I think is very critical, and NHA should seriously look at it. And also, I think on the package, what Sunil mentioned regarding the packages research, what has happened, that new set of package rates have been released by NHA just last week, I think. So that is available. So before we all go, actually, I want to just provide a small memento to our panelists, just to remember this day. Anyway, they will remember, I am quite sure, but still. So.
Thank you.
Thank you.
Okay, so thanks a lot. And I think in next 5 to 10 minutes, we'll start the next parallel session. And there are 4, one in this room and 3 other rooms. So wherever you want, please go on. And thanks a lot for joining us here. Thank you.
Attention everyone, the next session on capacity building under Ayushman Bharat and in the Ministry of Rural Development will start in next 5 minutes in this hall. Thank you. In this room, sir. I've announced also.
Okay. Okay. So the chair has suggested that we just do a quick mopping up. So for a couple of minutes we'll do that. जो आगे आ सकते हैं और आगे आना चाहें तो प्लीज इधर आ जाएं. Okay. Start. So thank you very much. We don't have a full hall, but we have a very interested hall, shall we say. In various international organizations where I worked after I left India in 2000 to work at the World Bank and then at UNDP, international organizations are extremely fond of workshops and discussions and deliberations. And we used to call this shift the graveyard shift, the one after lunch, because everybody is dozing off and just wants to fall off to sleep. So we will arrange some good tea and coffee, but in the meanwhile, the fact that we have such an eminent group of people here to chair and co-chair the sessions and make the presentations, I think this is going to be far from a graveyard. In any case, the concept of graveyard at this time of the afternoon in India is not very relevant. The graveyard actually, whatever we do it in the morning shift. So for us, in any case, it's not relevant. So we can start from there. It is my great pleasure and honor to introduce Mr. Devesh Chaturvedi, who is the Principal Secretary for Medical and Health in UP. Apart from the fact that I know him as a colleague, I also know him from when he was a very young officer. And since then, with every passing year, he's not only matured in age, but his experiences have been absolutely extraordinary. He conducted one of the best Kumbh Mela when he was in Allahabad, which was a massive, massive exercise, including in the area of health. Then we have Sangeeta Singh here, again from UP. And like I told her that I've heard wonderful things about you, to which she said, say it loudly so that Devesh can hear that. Then we have Mr. Prashant Kumar from the Department of Rural Development. We already had a very, very good presentation this morning from RD, from again one of my colleagues, Amarjit, who made an excellent presentation where he was able to show the convergence of health with everything else that RD is doing. And he made a wonderful point. He said that at some meeting he was at, the minister said that everyone in the cabinet should have health as an additional charge. And then I have next to me Amitabh Singh, additional CEO of the State Health Agency in Bihar. And again, with some wonderful experiences. As you know, UP and Bihar are two states full of challenges for not only this scheme, but generally, I'm also from the UP cadre, so we are called the Bimaru states. We have to do a lot to change that paradigm. And one of the ways that we can do it is improving fundamental capacities. I mean, we've already heard a lot about the PMJ and about the National Health Authority and everything that's being done. I have absolutely no hesitation in saying that 365 days is a very short span of time to roll out a scheme of this complexity and vastness. And NHA, I think, and the government of India, Ministry of Health, all other ministries that supported it, all our development partners, needs a lot of congratulation for having been able to do this. I mean, when I first read about it and heard about it, it was mind-boggling. So I think, yes, a good clap. So, given that a lot of things were done very quickly, and the expansion of the scheme has been very fast, there are things which might get left behind or sufficient attention to detail might not be given to them. One of those things is capacity development. Why? Because the tyranny of numbers and the pressure of achievement sometimes becomes so much that the depths in which we have to deal, they sometimes get sacrificed for the width and the expansion. So now when we are 1 year away from having started the scheme, this is really a very, very good time to reflect on the issue of capacity development. The National Health Agency, the National Health Authority itself is a very impressive organization. I must tell you that when I first walked into it, I don't know whether to say it as a compliment or otherwise, but it doesn't seem like a typical government office. It is full of young people with a lot of energy. There is a very flexible atmosphere of getting things done all around. People are with their laptops looking at problems, trying to find solutions, very non-hierarchical. So this is all fantastic. But it's also very flexible, sometimes, let's say, too flexible. So we need to find that fine balance where, while we are doing this expansion, we continue to consolidate and make the structures strong. As Devesh was just pointing out, one of the problems in states like UP and Bihar is that the fraudsters and the tricksters have so much more capacity than the rest of the system that it may be better in the longer run to be blamed for not taking the scheme forward so fast rather than taking it forward better and well. So this is that balance we have to find, and one of the key areas that can help us to make that happen is capacity development. Because if our institutional arrangements are solid, if our organizational structures are solid, and if our individual capacities match that, then if at the three levels, the enabling environment, the organizational structure, and the individual can all work together to achieve the goal and create a sustainable, sustaining organization, I think then we are on our way. So we've started well, but I think capacity development is one of those areas where a lot of work needs to be done. The second thing I'd like to say is that capacity development is not one of those things that happens quickly. So we have to understand that the capacity development is a slower process. It is not one of those things like impaneling a hospital. It needs much more. But the actual implementation of the scheme in the longer term will depend on strong SHAs and strong district units. So far we have done ad hoc, इसको ले लिया, उसको बुला लिया, एक कुछ बना दिया क्योंकि काम चलना है, योजना बनी है, चल रही है. That scheme has been prepared, it has to go ahead, let's get this one from here, that one from here, and we do some ad hoc flexible arrangements, but these need to be deepened by capacity. These need to be deepened by a very strong policy environment, by very strong legislative frameworks, by strong organizational structures that are meant to deliver, strong accountability mechanisms where these organizations are strongly enabled to be able to take care of these issues. And finally, a very strong system of monitoring and measuring results. Results are of two kinds. One is the regular results of a scheme. The other is the capacity development results. So as we see the results of the scheme so far, they are very good. But what are we going to see in the capacity development results? That is for this group to take forward. So may I now invite Devesh to take forward the rest of the session as the chair of this session, and I'm glad to see that a lot more seats have got filled in the meanwhile. So over to you, Devesh.
Thank you, ma'am. Welcome all the participants of this session. We were supposed to start at 2:30. We have started at 4. So what we'll do is we'll try to keep our time. We should not contribute in the further delay of the sessions today. So without wasting any time, we will sum up at the end. I will sum up at the end. We have 3 presentations today. First will be by Additional Secretary, Department of Rural Development, Shri Prashant Kumarji, Additional Secretary. then followed by Sangeeta Singh from UP, and then there is one presentation by Bihar, Shri Amitabh Singh, who is here, and then there will be a little bit of discussion where question answers can happen, and then the session summary, and we hope to close by 5:55. That's it. We would request the presenters to keep 15 minutes time frame given to them. So I'll first invite our colleague, Additional Secretary, to give his presentation on socio-economic survey.
Yeah, thank you very much, Devesh. Good afternoon. My presentation today is very focused and limited to capacity building initiatives that we have taken in the Ministry of Rural Development, and what are the gains that we have got from these initiatives. Ministry of Rural Development and Department of Rural Development, so far allocations are concerned, it is one of the biggest departments, and our allocation this year is 117,000 crores, and if you add EBR, that is extra budgetary resources, so it comes to 1.43 lakh crores, so not a small amount by any standards. And we implement various programs, and that includes wage employment program, that is MG Narega. Most of you might have heard about it. We have self-employment programs also, like National Rural Livelihood Mission. We have infrastructure development program like rural roads and rural housing. We have social safety net in the form of National Social Assistance Program. We have a skills development program which is known as Deen Dayal Upadhyay Gramin Kaushalya Yojana. So we have many programs, and as you can understand that if we are pushing 1.43 lakh crore funds through the states, to the beneficiaries, to various stakeholders, we require a very strong system of capacity building so that whatever we spend, that is well spent, and monitoring is also equally important. So in DORD, what we are doing is, so what we do in our various program divisions, that we plan at a very elaborately, then we execute, monitor and audit also, and the feedback loop that strengthens our further capacity building programs. We build capacities of communities, groups, individuals and various functionaries, which include government functionaries also, and the training is of both technical and non-technical. So let us take example of Pradhan Mantri Awas Yojana Gramin. This is a program which was launched by the Prime Minister on 20th of November 2016. So we are almost 3 years old, and the capacities that we build. If we talk about the technical capacities, it includes information technology, mobile technology. We also build capacities of various stakeholders, whether it is a group or it is a community. And the trainings that we impart, the capacity we build, we follow various models like cascading model. Then we also have classroom sessions. Then we also do some trainings which are on-the-job training. Like for example, in Pradhan Mantri Awas Yojana Gramin, we have rolled out a training program known as Rural Masons Training Program. And this is, and in the process of training, we actually construct a beneficiary's house. So it is on-the-job training program. And so if you talk about the individual beneficiaries, what we do is, we call a meeting of all the beneficiaries of a particular year at one place, and we have a 1 day or 2 days workshop trainings, and we sensitize, we build the capacities of all the beneficiaries about various aspects of Pradhan Mantri Awas Yojana Gramin, so that they can, so that whenever they start constructing their house, they don't feel handicapped about misinformation, non-information, etc., etc. Then we have we build the capacities of community and the groups also for various purposes like monitoring, the facilitation, for social audits also, and our functionaries who are mainly the government employees or those who have been co-opted like Gram Rojgar Sahayaks, etc., etc., and that includes e-learnings like IT sessions on IT, etc., etc. So I'll give you an example from Pradhan Mantri Awas Yojana. So our mobile application is a very important application, and we capture different stages of construction through our Awas application, what we call Awas app. And it is a very important tool for evidence-based monitoring. So if we want to monitor the progress of a program, so we have to build the capacities of our people, including the beneficiaries. So we train them, and then we capture different stages of construction, and that is populated on our MIS, which is known as Awas Soft, and the entire information is in the public domain. And any one of you, if you are living in a village area, you can drill down to your village and you can find out any beneficiaries, which will be showing different stages of construction. So the capacities that we need to build is extremely important for all the stakeholders. So these are the information that we capture when we go for the evidence-based monitoring. So like, for example, we give the beneficiary details, we also give the financial details, that at which point in time the installments, if you look at the second left table, it will give you the installments that were released on which date. Like, for example, the first installment was released on 7th of April 2017 and the last was released on 11th of August 2017. So in 4 months' time, the house got completed. Then we, as I said, then we capture various photographs also, and it is all in public domain. Anyone can access it. So there is nothing to be hidden. So transparency is our hallmark. So this is in a nutshell, but if you go to the site, I have divided it into three because it was not fitting into one, so that you can read also. So this is the first. So this is the information that we capture. So this is how we capture. So what all this has, the introduction of technology, the capacity build of all the stakeholders, what it has led to. It has led to faster completions. And when I come to the next slide, I'll show how it has led to faster completions. There is 100% DBT. Each and every house, the target under Pradhan Mantri Awas Yojana Gramin is construction of 2.95 crore houses in 6 years' time. In the phase 1, which was of first 3 years, the target was to construct 1 crore houses, and 84.34 crore houses have already been constructed. These systems are very transparent, evidence-based monitoring is there. So if you look at the number of houses that got completed, in 2014-15 it was only 1.1 million, which has increased to 4.7 million in the last year, that is 2018-19, and this year we are targeting 60 lakh, that is 6 million. So this is a reflection of what we are doing, and this is not possible. We could not have achieved this without building the capacities of our various stakeholders. Similarly, introduction of technology and the capacities of our people has led to reduction in number of days, average number of days in completion of a house. So in 15-16, when it was Indira Awas Yojana, the erstwhile rural housing program, and that was a smaller house, the average number of days for completion of a house was 314 days, which has now reduced to 114 days. So these are the takeaways from Pradhan Mantri Awas. These are the photos of some of the houses that have been constructed.
Next slide, बोली दीजिए.
Next slide, please. Next. So these are the photos of actual houses which have been constructed. So we have picked up random photographs and placed here. Next, please. These are photos from Assam. Yeah. Next. So let us come to another program which is known as Mahatma Gandhi Narega. And again, we have Rozgar Divas. So we train, we build the capacities of individuals. We also train them. Similarly, for the community and groups, functionaries, we also build their capacities. And, sorry. So what the capacity that we have built, what it has led to? It has led to the timely payments, which were only 30% in the last, 2-3 years ago, it has increased to more than 90%, a big achievement. We have geotagged all the assets and we have not involved any outside agency to do this. Our Gram Rojgar Sahayaks, they are doing this, and for this we have built their capacities. The e-musters are getting generated. It has led to transparency. We have evolved mobile attendance system. So all these, use of all these tools, etc., has led to speedy implementation of the program, more transparency, etc. Next, please. So this is what we have shown in a bar chart. So these are the improvements. Next. Some photographs. This is Mukhyamantri Jal Swablamban Abhiyan in Rajasthan, and this was carried out in conjunction with Narega scheme. So you can see the results here. Next. As I said, that all the Narega assets have been geotagged, and it has started from 2006. So we are back geotagging also. So the Narega was launched in 2006. So we are trying to geotag all the assets. All the new structures, they are getting geotagged, and 3 geotagged photographs are taken at the start, during the middle time, and at the end. So 3 photographs are available at least. Next, please. There are other structures which are coming up. These are the individual structures which are coming up under Narega. Next. So the third and the last program that I am taking today is the Deen Dayal Upadhyay Antyodaya Yojana, and this is known as NARLM also. So again, this is a very important program, and this leads to self-employment basically, and this is implemented through the self-help groups. And again, as I said earlier, we have built capacities of, and when you visit villages and if you try to interact with the SHG members, that is a pleasant surprise. The SHG members, they are so empowered, and it is a pleasure to talk to them. They are वो पुराने जमाने की वो शर्मीली बहुएं नहीं है. They are very forthcoming, they are very vocal, and they air their views very openly and very critically also at the same time. Even they criticize if something has gone wrong. Next. So 2.18 lakh crore bank credit has been leveraged, not a small amount by any standards. The NPAs have come down from 7.1% in 2013-14 to 2.2% this year. So again, a very significant achievement. We have 8 lakh Mahila Kisans. They have been mobilized into 86,559 producer groups, and 126 producer companies have been registered. So they are working on the lines of a producer company. So a lot of achievements are there, and this is all because we have built capacities. In this sector, the technical capacity building is not important. It is through the community resource persons, so it is one-to-one in a group. So it is basically imparting training to them when they are present. The technology is not of much importance here. Next, please. So you can see the funds leveraged and the credit links, bank loans outstanding. So it has improved a lot. Next. So these are some of the activities which are being taken up by the women SHGs. Next. So if you look at the right side, top 4 photographs on the right upper corner. So these are custom hiring centers. So what the ladies are doing, they have kept a few agricultural equipments which is difficult to be purchased by individual beneficiaries. So that is why they have come out with this concept of common facilitation center, and they give on hire various agricultural equipments. Next. So these are various aspects in which they do. Next. So this is all from my side. So in Ministry of Rural Development, what we are doing is, we are trying to build capacity building programs in our programs itself, so that we extend these programs to all the stakeholders, because if we build their capacities, it is easier for us to implement our programs, and this is what we are trying to do. Thank you very much.
Thank you, Prashantji. In fact, one of the main objectives of such workshops is to learn across sectors, and when we talk of Ayushman Bharat, especially when we are looking at in UP background, we have this problem of many people not knowing that they are part of the beneficiary envelope of Ayushman. There are problem of attrition of Ayushman Mitras, that there are delays in getting the pre-authorization or getting the payments, and it is linked to capacity building. Many times it is linked to capacity building and nothing else. So it's good to understand that once the capacity is built, the offtake of the program automatically improves many folds. So now we'll go to the next presentation by the CEO of State Health Authority UP, Sangeeta Singh.
Thank you, sir. I would just begin by underscoring the importance of capacity building by sharing an anecdote since morning. As we were coming down in the bus, some of our colleagues from other states were also coming with us, and we were sharing our experiences. And a very interesting conversation happened. Some colleagues from Arunachal Pradesh, they very cutely asked me, what is meant by Manthan? And I said Manthan is churning, and in the morning it was explained that when you churn it out, then the butter comes out, and then the nectar came out when the churning was done in the past. And so they understood. Then secondly, they asked, for a very long time we were wondering what pakwada is. So this is what capacity building should actually highlight, because if a person does not understand what you're trying to project to him or what the scheme is about, then obviously the scheme is bound to go haywire. So, we just coin a term and say we are going to launch a Ayushman Pakwada without understanding that some states which are not the Hindi is not strong, then what Pakwada means would be all jargon to them. So this is what highlights the importance of capacity building in the present context also. And we have been very strong in this right from the beginning. We have tried to build in capacity building and build in systems that will enhance the capacity of all the stakeholders. Now, my first slide is just to give you the extent of UP and the amount of hard work that we have had to do, the large beneficiary base and the extent of UP. It is spread in around 2.4 lakh kilometers, has a population of 23 lakh. Our beneficiary data is 1.18 crores. We have around 2,000 hospitals as on date impaneled. The beneficiary data is huge, the hospital number is huge, so we had to train. And plus the fact that the scheme is basically a software-driven scheme with several nuances that even we fail to understand in the present. So every day you learn something new during the process of doing claim processing or interacting with the hospital. There is some new nuance of the scheme that you come to understand. So capacity building every day consistently and thoroughly is very essential. Next please. So this is why UP is unique for PMJ implementation. One, we have a widespread geographical, cultural differences. We have the western side of UP, which is primarily a little richer than the eastern side, which has a larger, poorer population. We have aspirational districts that cater to another subset of the population. UP shares borders with around 8 states, so there is a lot of portability happening. Then Ayushman implementation is basically greenfield. We had RSBY, but it was not happening in UP. It was not operational for the past 3 years. So now we get onto the bandwagon of Ayushman Bharat as a greenfield state. Then we have the largest number of districts out of all the states, possibly 75 districts. So to disseminate information to these 75 districts to get across to their district functionaries, 75 times the same thing has to be told. That is a major exercise for sir and for me, because holding constant VCs, holding constant dialogues with them, communicating through letters, through telephones, through video conferences, that's a major exercise in itself. Then secondly, for PMJ implementation, Uttar Pradesh, we have divided it into 4 clusters, and then every ISA brings with it another set of history, another set of thought processes, another set of performances. So to train them in that capacity to take out the best from them, that is another exercise. Then we operate through 4 ISAs ISM, and then the time taken to travel. Suppose you just go out and say, okay, we'll go training on the spot. The whole state, if you travel from one end to the other, takes you more than 2 days. So having a major exercise for capacity building in that context is in itself a major task. Now, how we approached capacity building assessment? Initially, we did a primary training conducted for all the stakeholders because the scheme was new, and we understood that all the stakeholders, including the EHCPs, including the Arogya Mitras, including the hospitals, including our PM, including our district functionaries, including ourselves, we had to be trained in the primary nuances and the primary technical jargon of the scheme. That is the beginning that had to be done. Now, after that was done, we conducted these exercises at the state. A hands-on training was conducted. We had systems set up, and the people would come, and then we would train them into BIS systems, how the TMS would look like, what the Arogya Mitra was supposed to do, because that was a major task in itself. Then we went on to analyze the gaps that then we got from the inputs. So the gaps, then they showed us as to what more we needed to do, and then requests were raised for training modules and changes in the software. So if we understood that there is a certain part of the software that is not clicking well with the stakeholder, and then that is going to have a major impact on the scheme, we asked it to be customized as per our requirement, and I must appreciate NHA went ahead and a lot of it was customized as well for Uttar Pradesh and for other states as well. Then I think Uttar Pradesh is the only state where we have a training calendar as to how our trainings are going to go about. We have dates scheduled, months scheduled as to when we will have the trainings for which set of the stakeholders done. And every change, small change in the system, that requires a huge effort in communication. So a simple thing as like saying that plastic cards should not be uploaded for making golden cards because they lead to rejections in golden cards. This simple thing has to be communicated throughout the states and 75 districts to 2,000 hospital PMAMs, and you can understand the enormous issue that faces us. So the quantum of stakeholders and the widespread geography, for example, there was one form, that is the DMR, that requirement was abolished after some time, and then we saw that several months after that DMR forms were being uploaded, although that was not required by the system at all. So to train them into the particular nuances of the technical jargon of the scheme was very essential. Now, when we identified these gaps, what did we do? We identified Arogya Mitra capacity gaps and then resolved them by training. So, what gaps did we identify? The gaps that we identified were that Arogya Mitras, since they were lowly paid, less educated, but the most essential doorkeepers of the scheme, so their low technical knowledge would be suicidal for the scheme. So we had to train them in build upon their capacity for technique, for technology. Then there were errors in document upload. If they had to upload one particular document for claim processing, they would not be uploading it invariably. If they wanted some diagnostics to be uploaded, there was a very funny incident in which the Arogya Mitra uploaded, the system required both the sides of the document to be uploaded. So it says the front size and the back. So the front document was uploaded, it had the face of the person standing there, the person was clicked from the front, and then when the back part of the document had to be uploaded, the person was just turned around and his back was clicked. So there was no document that was uploaded, it was just a person with the back clicked. So that is the kind of gaps that we identified, and we had to take care of that. Then invariably, initial parts of the scheme, I think all of you must have experienced, there was a wrong package selection. Some package was there in which it was of a lower value which the hospital could have selected, but they went on and selected a wrong package, or they went and said that we want a unspecified package for this. Already some package existed because no one was aware and the packages were very large in number and it was difficult. So wrong packages were selected, which led to rejections, of pre-authorization and claims. So that had to be told to them that okay, when this particular diagnosis is there, then you have to click this package. Then every new AM, they needed additional training. So constantly as we have around 2,000 hospitals in panel now. So you can see the journey that has been through this, initially 30, then 50, then 100. So every week we had new people to train. So new Arogya Mitras had to be trained every off and on in order to give them a hand-holding about what the scheme needed to be done. Then the data is of course from 2011, so multiple changes have been there. Families have split up, new families have joined in, the children have moved out of their parents' house and new families have been created. The person was known by an urfiyat, maybe some commonly pet name, and then the name is actually different in the sec data than what he's been called and what is actually existing in his Aadhaar card probably. So all these gaps had to be filled. Then as far as the gap resolving of the ISAs needed to be done, next. And I think, yeah. So one last point, just stay here. One most important part regarding the Arogya Mitras was that soft skills had to be developed. Because Arogya Mitra is the face of the scheme in the hospital. If a person comes who's already suffering, and if he comes and the Arogya Mitra treats him badly or doesn't speak to him properly, the entire image of the scheme cascades. And this happened on the very first day of the scheme with us. One hospital that was just across the place from where the scheme was being launched, there was a very major hospital there. During the time of the launch, the Arogya Mitras were in the program, and some newspaper went to the hospital and someone was sitting there, and he said that I want my person to be treated under our Ayushman Yojana. The person didn't know anything about it because the Arogya Mitras were on the program. So this person says, okay, ठीक है, फिर तुम जाओ. Then the person says, because he is empowered now, he says कि मोदी जी ने हमको दिया है ये कार्ड करने के लिए. तो he says, okay, जाओ मोदी से करा लो. So if that kind of thing happens, you can see what the end of the scheme was. And the next day it was in the papers, and then there was a lot of damage exercise, control exercise to be done. We had to send a report to NHA. We were all awake till 11 or 12 at night just because of that one wrong statement that was being done. So soft skills are very important. Secondly, as far as the capacity building of ISAs are concerned, constant handholding are required because we've seen instances in which they have approved wrong pre-authorizations, they have not approved pre-authorizations within time, they have given auto-approvals, they have not approved it within the time required for them. So regular changes, regular monitoring is required. Of course, our tender takes care of that. There is a system for imposing penalty on them, but then how far does penalty work? Because after a point of time, they get demotivated and then it comes onto the scheme itself. So it is better to train them. So we had to sit with them every week and chalk out. My medical team would be sitting with them and saying, ये क्यों लगाया तुमने, ये approve क्यों किया, ये वाला तुमने क्यों गलत query यहाँ पे लगाई, how many queries are you going to put, and the hospitals are cribbing and so on. So that improves slowly. Multiple cases were erroneously approved. They were low in technical strength. Firstly, their own strength was not enough as much as we had required in the tender. So that had to be built up. Then there was a lack in standard operating protocols. What is to happen when what happens? So they had to be moved from step by step. They had to be given, and so they had to be trained likewise. Second set of training that was required was of the hospitals. The private EHCPs had to be trained because they were also clicking in wrong packages. Then they were getting grievances. They said that there was an issue with package cost. Then the specialities that they had chosen, they came around and said that, okay, we will only choose this particular specialty. We will not go with the other specialty that we had. So we had to train them and tell them that, look, we have identified a bouquet of specialities in which you can pick and choose and then level out your payments. So that had to be done. Then standard treatment guidelines, there was a lack, probably there still is a lack of standard treatment guidelines. So every time we would have a fight in our boardroom because two doctors would not agree on the standard treatment protocol to be followed. And that happens till date. So standard treatment guidelines had to be developed. We had to go ahead. And then there was lack of infrastructure. So what we took care of this lack of infrastructure in our public hospitals by giving them money 80,000 per public hospital for the kiosk to be set up. So for all the computer system and the biometric device, we provided 80,000 per hospital for the biometric devices and other systems to be in place early so that they could start treating the patients. Now, as far as capacity building goes, the types of training that we conducted, we divided into 4 parts. So the initial is the orientation training, that is the basic training, as I've said, with the stakeholders. Then regular trainings with the changing participants, new hospitals that are coming up, new PMAMs that are coming up. Second is a cascading awareness training. So out of this, the gaps that we have identified, the new learnings that we have identified, then there is a cascading training, another round of cascading training that happens. Then, because as Sir has already pointed out, fraud is something that needs to be contained right in the beginning. So then there is a fraud specific training. What we have done is that the triggers that we have identified and the parameters on which we are going to identify and judge our EHCPs, we have already communicated to them. We have given advisories saying that, look, these are the 23, 30 things that we are going to see in your claims, and you please see that you don't commit these blunders, or we will not be responsible, we will have to reject your claims. So that is the fraud specific training that we conducted for EHCPs, for ISAs, for the district level functionaries and so on. And then specific needs based training. So this was a major need, that some document is constantly being wrongly uploaded, and because of that the golden cards are being rejected. So that needed to go through across the state that, look, you need to stop uploading the plastic cards because the plastic cards, because the golden cards are being rejected. So that is specific need-based training based on the gaps that we have identified. Now, some of the best practices and the capacity-specific things that we have done in UP is that, number one, for IC and awareness, we have an Ayushman Sarathi, we've named it Ayushman Sarathi. This is an app that leads the patient. Any patient can identify, log on to this, download this, log on to this app, and just verify as to, suppose I have a heart ailment, so I will just click heart. It's an icon given there. I click heart, and the app takes me to the nearest hospital impaneled under Ayushman, which takes care of heart procedures. And not only that, the app will guide me through a GPS, through the Google Maps, to the nearest hospital that has facility for right, sir. So then we had bulk SMSs, we have periodic newsletters being printed, we have transport and radio advertising. Then we did Arogya Mitra, Arogya plastic cards distribution. For fraud prevention, we did a capacity training of ISAs and DIU, the district implementation units. There was a constant intervention from the side of SHA. Then we circulated a list of the triggers that we had generated. Then beneficiary focus drives, we had Ayushman Pakwadas. One of them is still going on, in which our main focus is building of golden cards. Then we are trying for a village level saturation in this. Then we've tried to encourage the public hospitals to come forward. We have identified district implementation unit members to take on CHCs and how they're going to do that. So these are just pictures of these. Next, please. Now, another is that we have developed a state tracker. As I said, we have a calendar for training. Then cascading information to health worker. We provide information to each ASHA and the block level workers for our training in this thing. And then there are inputs. There is a specialist stream that further gives us input on our fraud mechanism, on the things that we need to do. So that is a group of AIMS doctors that we have hired, and for every such intervention we provide them a certain bucks, and they get back to us and do it for us. So till date we have carried on around 150 training sessions, around 3 equal to or more than 3 rounds of each for each stakeholders, for nodal officers, for government medical hospitals, for private hospitals, for district managers, for DIUs, to cluster-wise ISA, to Arogya Mitras, to field-level functionaries, and so on. These are some of the best practices. You can see the dates identified there. This is our timeline for activities that we went around till August. We did the second and third round of the DIU, the ISA, and the Arogya Mitra training. These are certain pictures of the trainings that happened. the way forward is that we have to do capacity building for the new hospitals and the Arogya Mitras. Recently, in the near future, we are going to have a round table for the private corporate hospitals we are planning for with higher officials. Then the bronze certification program that is being initiated by NHA, we are going to do orientation on that. And then we are doing training for Gram Pradhan sir. Through the Panchayati Raj department, and then the training of Anganwadi workers. We have printed hospital booklets that we will distribute to the districts and do that. At the end, my last statement is that and robust IT system is the essential for any kind of capacity building exercise, and NHA needs to be commended for the robust IT building exercise, because then we can identify the data, we can take out the dump, do the exercises, find out the triggers, learn through it, and then give further training. So this is all from me. Thank you.
Thank you very much, Sangeeta ji. You spoke from your heart and we had to stop you because of your experience. You could have gone for 10, 20, 15 minutes more. In fact, I'll just add one thing. In fact, we were doing video conferencing of all the CMOs a few days back. And the issue was that out of 750 odd community health centers, about 300 were impaneled, though they were deemed impaneled. So we were asking, why aren't you putting your system into the empanelment list by registering? And the answer was that since we are not having a specialist, we are not impaneling. So this was the capacity of the CMOs after 1 year of the program, that they were waiting for a specialist to come so that they can be impaneled in the. So we were telling them that there are so many packages where you don't need specialists to come out or into the system. So that was the chief medical officer of the district heading the medical team after 1 year of the program. So the necessity of capacity building cannot be overemphasized. So now I'll come to Shri Amitabh Singh ji, additional CEO, will give the Bihar experience.
Thank you, sir. Actually, CEO SHA has covered all the aspects of capacity building in such great details that I feel that I should cut short on my PPT rather than repeating those issues. And it was like in all the dimensions it was covered in such a beautiful manner. But next. Now, why there is a need for capacity building? As Madam has pointed out earlier, capacity building is one field which often gets neglected. Now we have institutions like we have the SHA, we have the ISA, we have the network hospitals. So in every institution, guys keep in joining and like they keep on leaving the organization. So there is always a typical need of training all those newcomers. Now that is what the second dimension becomes. The human resources capacity needs to be built on day-to-day basis, and the knowledge management, I mean to say that NHA keeps on coming up with new versions every quarter in terms of software or in terms of skill sets or in terms of rules and regulations. So these are the three dimensions which actually lead to the continuous capacity building workshops and trainings. Next. Now, how do we do that? Bihar being actually a very big state and having 38 districts, and the problem with this is like most of the time, almost 4 to 5 months, we are flood affected, difficult to access areas. So at that level it becomes really difficult for us to give the continuous training and handholding programs. Now, how do we do that? So we conduct a gap analysis thing, and initially we had a feedback mechanism. Actually, sir, I would like to share with this August gathering. When we started to implement this program, we kind of conducted state headquarter level training for all the Arogya Mitras, civil surgeons and IT persons. But when we went for 3-4 months, the results were not coming. Then we finally realized that there is something amiss, and then we started sending teams to the district headquarters and we did a hands-on training. Then our number of pre-auths started coming, and then we almost doubled from the level of maybe January, February till now. So we are almost, we started from 50 odd pre-auths per day, and we have reached the level of 600 to 700 per day. So that is how you can say capacity building affects the performance. Next. Next part. Next. Now these are the challenges we have already discussed. The guidelines keep evolving, and the basic hurdle in this, in our state, is the Arogya Mitras are not dedicated Arogya Mitras in our public hospitals. So the higher rate of attrition makes it all the more difficult for us. And then they are not tech savvy, so naturally we need to build on their technical skills all the more. I mean, these are all also the negatives of any scheme. The lack of manpower and resources required in public hospitals are always there. Next. Now these are the few of the best practices that are adopted by the state. We basically now have adopted of a WhatsApp kind of approach and using YouTube video tutorials in vernacular languages that my team has developed in-house, and then whenever we get a new launch or a new version launched for BIS or TMS, we make a video tutorial in that vernacular language for that for that specifically that geographical area, and then we upload it on the YouTube, and then we put a link on the WhatsApp, and that's how that makes things easier for us. Now we are conducting a recruitment drive for state and district level positions. That is another part of capacity building actually. We are poorly manned at state headquarters as well as districts. Now these are the methodologies. Basically, sir, I would like to say where we lack actually, we need a training center. We don't have a training center, dedicated training center. We need to institutionalize these aspects actually. We don't have dedicated resource persons. I work through my consultants and few of my dedicated officials. But we need to have a dedicated capacity building cell kind of thing so that we can keep on doing these and basically those network hospitals who keep on joining us, they need to be actually trained. We also need a particular module dedicated for each of the stakeholders, ranging from Arogya Mitras to the HOD of the departments. And then finally we do have very rudimentary kind of assessment tool, but I would request NHA guys to develop an assessment tool kind of thing when we impart training. So we need to have a designed module kind of thing and then an assessment tool. Actually the professional HR agencies kind of, they do it this way only, but हम तो ऐसा स्टेट गवर्नमेंट जो इश्यूज हैं हमारे पास लिमिटेशंस हैं तो हम तो अभी ऐसे ही कर रहे हैं. But I would request NHA authorities to look into it and make it more professional and thoroughly professional rather. Tracking mechanism and evaluate the impact of training. चलो ये आगे करो time. This is one aspect madam ने highlight किया है ISA के तो we have like 38 districts and we have like 120 odd personnels, but every second month or third month the district coordinator leaves or the district grievance nodal officer leaves. So that is the greatest bottleneck and we need to keep them training on and on. The medicos also leave, the medical auditors, they are also on like never in full strength working. तो कभी भी ISA ने नहीं किया तो we always need to train them on and off. Next. Now this is the roadmap for stakeholders, sir, and I would like to again address the thematic areas. Now the core program areas is empowering our ISA, and then the IT tools and data analytics. Now we need to develop these actually. Now we are into the second year of the scheme, so we need to do something more professional in terms of developing these tools and developing the data analytics things. IC and social mobilization things keep on going and we keep on doing that. The most important aspect is we don't do regular audit kind of thing. Grievance redressal, we keep on doing it. But professional audit, we lack in that and we need to actually capacity build of our own in-house team as well as the ISA's team. Next. Now, this is what we have done in our state. We actually have been helped by ZIZ and the ADRI, as well as the community-based organizations like Jivika and NGOs like Care India and all sorts of capacity building activities. And we have also taken some kind of help from NHM also. Now, this is one case study where in the district level orientation cum convergence workshop, we actually conducted it on a war level basis in the month of August and September, and the basic purpose was to increase the intersectoral participation. So we actually had a very good experience, and the outcome was that in those months we actually had a shoot in the number of prios actually generated. So that is how capacity building affects the whole scheme in a way. Now the planning ahead is we will always go for refresher trainings, and that is the need of the hour. And we will actually focus on basically designing user-friendly training module, which is a need for the hour actually. Chalo, thank you.
Thank you for the presentation regarding challenges in Bihar. In fact, Bihar and UP will be having similar sort of challenges in terms of capacity building, especially of the grassroots level workers and the attrition issue. Now, we come to the last presentation, and fortunately we have the CEO of State Health Authority Assam, and I would request her to give in 5 to 7 minutes what she has to say about the importance of capacity building with respect to this scheme. Thank you.
Thank you, sir, and good afternoon, everybody. Can we start, please? How does one do it, ma'am? Yeah, thanks. So a quick preview of what we are. Only thing is, we have told you. You can. I think. Can you read it? I don't know if you can. But the thing is that, yeah. There are, if you just see, they have written parent hospitals 302, but we have 305 hospitals, and out of that 161 are government and 144 are private. And these are the beneficiary families, and we are also, I'm glad to tell you that the State Health Society also has the Atal Amrit Abhiyan, which is a state initiative. So much of the best practices in the Atal Amrit Abhiyan is also incorporated in the PMJAY. Now this is important for me and for you to understand why Assam is unique, because we have a geography which is a little different from the rest, and the total number of districts are 33, and if you just see, there is the daily allowance, which is a best practice which we adopted from the Atal Amrit, because that gives some kind of a fillip to the person concerned, and when you have a daily allowance of cash benefit of 1,000 per day up to 10,000 per day, this is not provided in the PMJAY, but this is part of our capacity building efforts in Assam. And then we also have the transportation costs, which is 300 to 30,000, and for outside, of course, we have it till 30,000. This also is not provided in PMJAY, but this is an incentive system of the government of Assam. Now, regarding this, the training programs, we hold it at very, very regular intervals. We plan to take it down right to a zonal level capacity building program, which would involve Ashas and Anganwadi workers. And we have the hospitals, the doctors, along with the PMAMs, all being taken care of in our programs. And we have the training materials also prepared in the local language, so it's easier for people to understand. And we also plan to take it down right up to the Village Health and Nutrition Day, which is, of course, done by the NHM, but we plan to take our training programs right to the field level. these are just a few of the stakeholders that we have. In fact, like Madam has just said, capacity building it starts not only just from the bottom, I think it also involves the top level functionaries. So we have at regular intervals, we do have training programs. And yes, ma'am, I think this also is important to have soft skills. It's important for people for the PMAMs to actually come forward and help the beneficiary, because that is one important aspect we really focus upon in Assam. The next. For this, the PMAMs need constant training. We are focusing, like I just said, on soft skills. Then we also have a post-training questionnaire, which is kept secret, and just after the training, we let them have it's a very short questionnaire that we have developed, and we normally have this just after each training that we have. Then the field level staff and also the ISA. We meet the ISA every 15 days now, and we keep a conversation alive between us so that any gaps that we find or they find is brought to the fore and everything is taken care of then. These are the challenges which we face regarding package amount, package selection, but I feel that if the PMAMs or the people involved in the system are properly trained, then these challenges can be met, and that's what we are trying to do. We try to identify the gaps, whether it's a package selection, because we do have a problem, because again we have different package rates for the state program and package rates for PMJAY, and but now we are trying to reconcile that and bring all the rates under the Atal Amrit into PMJAY. So I think we'll slowly, when we develop ourselves more, then we will be able to get this challenge also fixed. These are just the capacity building programs, the type of trainings that we have conducted, the orientation, the monthly PMAM refresher trainings at district levels, like I just said some time back. We plan to take it right up to the zonal level. We've already started making groups where we will divide or subdivide the districts, the state into different zones, and we will take it down, and that's how we plan to increase our capacity building. And these, we also, like I said, if you just see the second last, it's the frequency of trainings, because I feel that when we do not really meet, or the conversation is not kept alive, that's when there are more chances of any kind of problems that might arise, and that's what we are trying to do. We are bringing in all kinds of stakeholders. We are trying to bring in the ASHA workers, the Anganwadi workers, and within us also, within the SHA, we are trying to, in fact, we've already asked the NHA, the Deputy CEO was with us for some time, and we've asked him that we should also have some capacity building programs, and that's important for us. Just some pictures, because my Honourable Minister is also very keen. Each time that we have training programs, it's the Honourable Minister is always attending, and he's the one who has taken the initiative of having the questionnaire. So that's just some pictures of it. Like I said, we've translated much of the material into Assamese, so it's easier for people to understand. So, sir, what we feel is the capacity building is important. Not, like I said, I don't want to keep on harping on it, because I think that 5 minutes card will be up soon. But I think it's important for all of us, for the SHA staff as well as for everybody. And I think this has decreased some of our grievances, because when we had dozens and dozens of grievances, now it has come down to quite a few, because I think people are trying to understand what exactly is going on, especially when the package rates and everything are explained getting to them right at the district, the hospital coordinators or we have something called the hospital administrators, which are appointed in the government. So when the PMAMs cannot do it, then they take it to this next level, and that's how I feel the moment everybody is involved and all trainings initiatives are not given just to one particular group, but it's taken to all. That's when we are planning to solve all our problems, and that's how we're doing it. Thank you very much for giving me this time.
Thank you, ma'am. And we'll have a 5-minute opportunity for any queries, questions, or suggestions. It need not be a question, it can be an additional suggestion for all of us to learn based on your own experience of handling these programs. So it's open for discussion.
So, can I go?
Yeah, sure.
My name is Gaurav Tripathi. I represent Aditya Birla Health Insurance Company. So, I just want to kind of, know your experiences, all SHAs. The scenario when it was managed through an insurance company compared to is a trust-based model. So how difficult or easy or what's your take on that? Is it difficult in terms of managing directly, or you need additional capacity building to build the capacity at the bottom level?
See, academically, it would look easier for an insurance company to take on all the burden, and we would think that it is less burden on the SHA. But actually, I think trust model, we are working in a very fairly. Because what happens is that the primary problem was as to the payment capacity.
Right.
There is a clash of interest in the insurance company. You would not want to pay because it's against your business model. Whereas since the government is taking care of the entire claim burden, therefore, and it is an eligibility scheme, so the government is not hesitant. In fact, every day I'm getting slack from my principal secretary and my CM that why is it that less pre-authorizations are taking place. So they would be very happy to have more people treated under the scheme. Whereas conversely, under the insurance model, it doesn't gel with your business model at all. And that was primarily the reason in UP, because initially the hospitals were hesitant because they had such a bad experience under RSBY. I mean, I had to face a few court cases because of that because the premium was not paid, so the hospital claims were not paid, and therefore the hospitals were hesitant. Some hospitals still come to me and say कि बहुत खराब experience हुआ साहब RSBY का, insurance companies ने पैसा नहीं दिया मैडम, हमें पता नहीं मिलेगा या नहीं मिलेगा, so we are hesitant to come on board. But now that they say that the claims are flowing, now they are easily coming on. So I think trust model, we feel that God is our witness. Yeah. I hope it goes well, but that's what I feel.
Thank you.
Good evening, ma'am. This is Samrit from IIT Kanpur. There is one big challenge that I would like to ask, that how do you ensure the performance and reliability of the ISAs? Like in both the states of UP and Bihar, we have seen that the forced approvals are going about 20%. So more than 20% of your cases are being auto-approved by the ISA without even seeing them. And we had also conducted a time and motion study where we made the people of the ISA sit and process the cases before us. It was seen that the quality of processing is so poor that they are literally processing one case, a claim, in less than 1 minute. So how do you ensure the reliability of the performance of the ISA? And one more thing, that how do you ensure that the gap between the ISA TPA, the person processing the case there, and the hospital? So like in the case of pre-auth, what mostly happens is that there is a query and then that is not answered. So that puts a burden on the patient. So how do you tackle these two challenges?
Okay, so you getting into the operations now. That's a very good point that you have raised. The first is, I think initially you were talking about BIS, is that it? So we have developed a system. The system goes like that auto approvals are not there in UP. We have not gone for systems like auto approvals.
No, not BIS.
I'll come to that. But suppose they have wrongly approved or wrongly rejected. So if they have approved a wrong BIS, then it is in the system, and we just wish that the real beneficiary would turn up, and we have the system of, putting that card, cancelling that card. But if they wrongly rejected a claim, then it flows to the SHA, and my people in the office, they are sitting and then they analyze it, and we have had cases in which they have rejected it, but we have had to approve. But if that happens, the only answer, if I had to give a one-line answer, that is penalty. So till date, we have imposed a penalty of around, I think, 80 18 lakhs and some of it is more to come. So we had it inbuilt in our tender document itself that if they give wrong approvals that we later reject, or if they reject a BIS thing that we later approve, then there is a particular clause that states the quantum of the penalty also. So as per that, we calculate the penalty and we impose it upon them. And then we are coming to the second part of your question as to numerous queries on their part that the hospitals cannot resolve. That our district implementation units, we have put it upon them. The district implementation units, if we see that in one particular hospital or in a district there are a number of queries just pending and the hospital is not able to answer, then we share the queries with the district implementation unit guys. They go to the hospital, get them to open their portal and then sit with them to help resolve the queries. And of course capacity building is the basis for that.
In the case of forced approvals, actually I was referring to the 6-hour window that is exceeded in pre-op.
We have a penalty for that also.
The only answer is we keep an eye on ISA's all kinds of activities, and at the end of the month we prepare all kind of violations. There is a list prepared by our consultants and we impose the penalty accordingly. That's it.
Can I ask one more question? So till now we've been discussing about the capacity building at the operations level of the PMAMs, of the software solutions, the approvers. Just want to get 2 cents of the thoughts of the panelists on the capacity building on the clinician side. Are we looking at capacity building for better diagnosis, faster diagnosis, so that it streamlines the entire system and the flow and the service delivery?
Hina, we did a capacity building exercise of the private hospitals also. And when we do that, we face a lot of counter questions. Galat approvals ho rahe hain, approval nahi ho rahe hain, claims nahi aa rahe hain. So that is a forum in which you can just sit and there would all be clinicians and there would be clinicians on our side also. And sometimes we take help from NHA people also. We ask you to come on board. And then we sit and answer their queries. Recently what has happened is that in one of these workshops that Sir was heading, these hospitals, they said that a lot of their claims are being rejected unnecessarily. So since now we have the option of revoking, so we ask them to put across to us and then one day we sit with our medical team, go through each claim separately, and if it is required we revoke it or they come in grievance. So of course that is a very good suggestion. Now I think the second year we'll have to focus on that but doctors never agree with each other. Let me tell you that. They would never agree with each other, but then that's a good thing that we'll take it up. I was talking about standard treatment protocols, no? So that is the basis for being developed. I mean, you cannot force it upon people because they have a certain knowledge, but I think that is the answer.
Ma'am, this is me.
Okay, please.
My name is Dr. Ramya, and I represent a startup called Next Year. So here we're talking a lot about, 5 different governments sitting here and then talking a lot about the training and, the attrition rate and all the issues of training. So we actually worked with GE Healthcare in order to develop a solution which could get away with training and then come up with a hand-holding kind of tool. So training, because you need to retrain, and then attrition rate and all of these are really tough to handle. What if a tool and just a mobile app solution is given to them, which will really not let them go to the next step unless they do the first step properly. So that would avoid the need for training, and also it would give them solutions right at the same time when they want, so when they need anywhere, anytime. So there are different governments sitting here, so I just wanted to understand if any, so if anyone is looking for solutions like that and then given an opportunity to build solutions which could handhold people more than train them.
Yeah, that's good, but I will again repeat what our friend from Bihar said, that nothing can replace the hands-on training, especially for those people who are working in the village or the semi-rural area, where seeing the mobile app and understanding, even we are at our age find it very difficult to have online modules, understand and undertake certificate courses. So, of course, but technology is certainly necessary where the level of awareness about IT is relatively high, maybe in the doctors or maybe in some of these ISAs, though educated people are coming. Certainly it is necessary.
There is a situation, so far management of cancer is concerned, usually it is a multidisciplinary treatment. So suppose a patient with the cancer first undergoes surgery, pre-authorization is necessary to get the surgical package approved. Again, the same patient will have to take chemotherapy, again separate pre-authorization, again the patient may have to undergo radiotherapy, again another package will have to be approved. Can there be a mechanism that the single pre-authorization, otherwise the same patient will have to go 3 times to get this pre-authorization approved?
I'm sorry, sir, I'll not be able to answer that. That relates to a package thing, basically. And I think NHA should answer, I think. And I think they've done a pretty good job in revising the packages that recently happened. And I was told by my medical team that that's the best type of revision that could have been done. So maybe it can go further on and have a further improvement, but certainly we also face, especially for cancer treatments, we face a lot of these difficulties. There is a new drug that is in market and it's so costly that it doesn't come under the 1 lakh limit, and then we are at a loss as to what to do. One of our cancer institutes raised this issue and we put it upon NHA to do that. I think we've come up with a package of that kind, but let's see when it is. I think we can only say when it is there, the new packages. Yeah.
Right. So at the end, thank you very much for this lively presentations and interesting discussion. I'll just in 2 minutes sum up. Clap for everybody, all the presenters and questions. Thank you. In fact, we'll just summing up, as it is said that the strength of the chain is its weakest link. So that is what capacity building has to do. The weakest link has to be strengthened so that the program runs seamlessly. Assam, Mr. Prashant Kumarji talked about the multi-stakeholder approach which is necessary, where all stakeholders have to be taken into board on board. And then there was an issue of technical versus non-technical, which in our our perspective, it is the medical service providers which have to be trained so that they know how the packages have to be, and the standard operating procedures are standardized to some extent. The ISAs, the claim processing, and the beneficiaries and the local political leadership to make them aware that who are the beneficiaries, who are not. UP, of course, talked about the need of soft skills and the training calendar, and that it has to be an ongoing exercise. Bihar highlighted the importance of the hands-on training and also the challenges of attrition, where, again, the same issue of ongoing capacity building exercise has to be there as a strategy. Assam again discussed about refresher training and that the conversation needs to be kept alive because people tend to fall back into and deviate from the standard processes once they are not refreshed with time. And then she also talked about the impact of training initiatives in terms of improving the parameters of the scheme, the performance parameters. So on the whole, we have highlighted the issues, what has been done, and a few issues which need to be taken further in terms of the capacity building of the medical practitioners, the package rationalization, and all those things which are still a work in progress. And I'm sure after this workshop and the sensitization which has been undertaken, the policymakers will keep their focus on these aspects also. Thank you very much for this.
Thank you very much. It has been a privilege to hear the views of this exceptional panel. I have the pleasant duty of handing over mementos to all of you for having participated in this. everybody.
So this will be mainly what I get is yours will be good in training in operating equipment, maybe high accuracy and high because I'm also in charge of all the research. So I have that's why the requirements are other. I just want to know how much.
Plus minus था ना?
I did not wanted initially तो he wanted an independent country. मैं वहाँ का महाराज हूँ, मैं प्राइम मिनिस्टर हूँ, ये सब अगर वो नहीं चाहते तो आराम से इंडिया में आराम से इंडिकेट लगाता हूँ, सरदार वल्लभ भाई पटेल कर लेते भाई. History is history.
Never had about the soft corner.
Yeah. So we can discuss and discuss, but history can't be changed. Ifs and buts are there in history.
This is fact. Since 1977-78, when it was 40 paisa kg atta for them, and open market was 210. But we are discussing here, the last beneficiary was not getting anything. Slowly and slowly, at urban level and semi-urban level, maximum rural. Thereafter, nothing was going down. And actually, they had gone, whenever you give them something, they will go to the other side. And they exploited the situation.
Good evening, everyone. Yeah.
Just a minute, just
He has come. I'm sorry. Actually, I was the convener of one of the parallel session, and it has just got over, and I rushed to the hall. My apologies for the delay. So, as we have all discussed before also, so this is the working group 5, which has got the mandate of strengthening public hospitals through PMJ, and I am the convener of the group, and chairman of the group is Mr. Pankaj Pandey from Karnataka. And Rahul, can we start the presentation? So, how we have thought is this is the composition of our group, that we have AIMS Delhi representative, Dr. Abdul, and then these are the states, and then we realized during the discussion that Karnataka has some interesting things to share in this group. So we invited Karnataka, which was not earlier in the group, to be a part of this working group. And I just now discovered in the parallel session which was going on in hall number 5, that even Kashmir has a few interesting tales to tell on this topic. And I invited Dr. Rashid, who is a medical superintendent of District Hospital Pulwama. And I am actually impressed by the presentation that he has just given. And in the course of this discussion, we will request him to share the experience of District Hospital Pulwama. And next slide. So what we have thought is this is the basic draft presentation that we have made. We are going to start with this. Then we will request our chair to actually steer the discussion. And then there will be question answers. And then after that, whatever changes that the group feels fit and that will be made. And then after this is the introduction presentation that we are going to make. Then there will be opening remarks by Dr. G. Devan from CEO of Chandigarh. Then there will be panel discussion which will be steered by Dr. Ratan Kelkar. Then there will be question and answer which will be Dr. Vijay Kumar we have requested, but so then chair will help, then conclusion by the chair, and then closing remarks. So this is the presentation, the draft presentation that has been mailed to all of you. I think, I hope everyone has gone through it. So this was the terms of references that were given to us. What are the challenges that are being faced currently by the public hospitals? And then we went on and discussed what was being done by the public hospitals before the advent of ABPMJ. Then what is being done, what was being done to strengthen the public hospitals briefly before ABPMJ. Then after the advent of ABPMJ, what has changed? What are the what is the difference that has been made to the public hospitals? Then what are the present reimbursement system for the fund that is being received by PMJ? Then how to promote development in public hospitals through PMJ? And what is the roadmap for the future? So with this terms of reference, the working group met through the VC on 12th September, then 17th September, and then on 20th September we met physically, in which only Chhattisgarh could not attend. And at that point of time, we requested Mr. Pandey to actually, since Karnataka has had a very rich experience of implementing this scheme, so we requested him and he kindly consented. Next slide. So problems being faced by the public hospitals as per the document that we have circulated beforehand. So we could group it under these broad headings: deficiencies in the infrastructure, deficiencies in the manpower, mismatch between the capacity and the patient load. We all know this. The public hospitals are basically overrun by the patients. Then equivocal quality of services. Now, this is something which is a debate which is going on between the policymakers and the hospital staff, that with so much of patient load, how can you expect quality? And then the policymaker says that if you give better quality, then maybe you get better infrastructure also. Then high out-of-pocket expenditure is one of the problem that was being cited by the general public, and policymakers have actually taken note of it, and ABPMJ is actually an attempt to sort this out, this problem also. Then long lead time in upgradation is something which any person who has worked in a public hospital will actually can go on and on. That even if you identify that this is the problem, even the smallest of things will take a long bureaucratic route to be sorted out. Then declining confidence in public health care, we have all experienced this. The people who have worked in the public hospitals before the 21st century knows how much confidence the general public had in the public hospitals, and with the advent of the private hospitals, how this has actually eroded in last 20 years or so. Next slide. Then this is before the advent of ABPMJ, we have already discussed this. Next slide. Then this is something which at NHA we felt, this is of course open to the group and chair, that ABPMJ actually brought in differences in these things. Governance, yes. Then patient, the finance will be the first thing that we will mention, that the treating hospitals started getting access to the money. The patients that they were treating, the money started getting deposited with the public hospital's account, and it was put at their disposal. Then governance, as we have found in the last few meetings, that this fund was actually placed at the convenience of the hospital. Of course, there are minor differences in the different states, as Karnataka has a very nuanced system. In PHC, they are giving 50% of money to the hospital, and rest of that is being parked with the SHA. In medical colleges, everything is given to the hospital so that they can provide better services, they can improve their services. Then patient care, of course, out-of-pocket expenditure, we have seen that has gone down. The patients are now being provided everything from the hospital. The quality of care, we may like to say that it has also improved, and the success stories that various states have shared with us is also a testimony to that. Then motivation, incentivization is being given to the government hospital functionaries also, and everyone who has worked in government in any capacity knows that you cannot get even a single paisa more even if you are the best worker. And the worst of the worker will, sorry, this is a politically incorrect, but a worker who is not maybe pulling his weight, his or her weight to the maximum, is also getting the same pay as a person who is putting in the best effort. So this is something ABPMJ has actually changed, and actually you can, a hospital superintendent can actually incentivize its good workers. So, and hopefully it will lead to a better motivation and better responsiveness from the hospital staff. Then decongestion is something which many people didn't think about it, but look, the 40% population didn't have any choice. They were at the bottom of the socio-economic ladder. They didn't have any choice. Either they just ignored their disease and chose not to receive any treatment, or they were forced to come to the government hospitals. They didn't have any choice. ABPMJ has actually provided this choice to these patients, and now these patients can actually go to private hospitals for the treatment. And we feel that this may actually decongest the public hospitals to an extent, and this may help improve their quality, and the public hospitals in turn may feel motivated or feel it may result in a healthy competition between the public hospitals and the private hospitals. This is something which we are hoping, or we may actually design our services in a way, our reimbursement system in a way that it actually happens. Next slide. So these were some of the stories, heartwarming stories that were being shared by different states. There is a hospital in Meghalaya which has actually equipped its lab through these funds. There is a redesigned air-conditioned patient ward in Meghalaya, although we felt, what is the need of air conditioning in Meghalaya?
It's in the plain areas, no? It's not in the hilly part.
It's in the plain area. Okay.
It's a hot area.
So when we listen to the name Meghalaya, we feel
King of rains.
So okay. Then in Patna, Bihar, we have had again a same kind of story. Then these are 6 of the stories that we have tried to depict. Next slide. So model guidelines, this is something which we thought maybe this group, now this is open to the discussion, that maybe we can, this is a little bit out of Kerala model, Karnataka model also, that we define every level of our public hospitals in terms of services. Now if we we standardize every hospital in terms of services, then actually we will be forced to define the manpower, the equipment and the infrastructure that will go in to provide that kind of services. Now if you define these kind of services and you put it in the public domain that these are the services that you can actually expect from this hospital, then the public is going to demand that kind of services. But having said this is easier said than done. The hospital head should be empowered then to actually utilize the ABPMJ fund to actually fill the gaps which are there in terms of manpower or equipment or infrastructure, so that all the services are available all the time in these hospitals. So if the hospital head is empowered and the local public is aware that these kind of services are expected, so we feel that somehow the services level available in the hospitals are going to come up. Then the other thing which has come out in the discussions is that there should be organic integration of the health and wellness centers and PMJ. So PMJ is providing secondary and tertiary treatment. Our public hospitals have not been able to provide, so we have brought in the private hospitals also, which were in any case providing more than 60 to 70% of inpatient care in this country. But at the end of the day, the government will like its public hospitals to come up to the challenge, so that we are not forced to be dependent upon the private hospitals. So maybe we start designing our services in a way which Karnataka actually initiated beautifully in the meeting on 20th, that every patient is mapped to one or the other health and wellness center. And this health and wellness center is actually aware that what services are available in which hospital of the nearby public hospitals. So it can actually guide the patient to that public hospitals, and that public hospital should actually, if either it is able to provide the services, or it should actually guide the patient to the relevant private hospital. And this relevant private hospital, once it has provided the treatment, the patient should actually come back to the public hospital system, and there the follow-up services should be provided by the public health infrastructure to this patient. This will actually complete the continuum of care, and in the long run will result in strengthening of the public hospitals. And maybe this group can actually suggest some ways of instilling a sense of competition among the public hospitals, among two different public hospitals, and between public hospitals and private hospitals also. So these were the model guidelines that we have drafted at NHA based on, basically these, the whole presentation is based on the inputs that have been provided by different states. And now after this, I invite Dr. Devan to please give the opening remarks.
Good evening. Good evening. Today's Ayushman Bharat is an unimagined invention for a common man, a game changer in health scenario of this country having global recognition. The achievement in terms of healthcare delivery at primary, secondary and tertiary level to the beneficiaries of Ayushman Bharat is a dream taking shape in front of us. On completion of 1 year of Ayushman Bharat, we need to move forward to brainstorm and list out the gaps felt during the year with innovations to strengthen our public hospitals. Today our Working Group 5, Strengthening Public Hospitals through PMJ, to take forward, having around 30 years of working with the hospitals, we need to work on fully operationalizing the IT module in each hospital impaneled in respect of e-hospital, articulated with the capturing of beneficiary of Ayushman Bharat in respect of each and every service rendered in the ward, operation theatre, labour room, and the medicine consumables made available to the patients, which will go a long way to capture the data on the basis of which future planning can be done. The state/regional IT network has to be established in respect of the patients being referred from one hospital to the other in order to ascertain the availability of services, that is availability of the bed, doctor, operation theatre, etc., so that the referral becomes more meaningful for the beneficiary with regard to the delivery of the services. Similarly, on the PPP mode, with the implementation of the Ayushman Bharat, the state-public UTs could not keep pace with the upgradation of their supporting services, hence gap in the services and the price escalation for the hospital vis-a-vis package amount. The hospital be allowed to adopt PPP mode for the supporting services made be ultrasound, CT scan, MRI, specialized lab, test, etc., for which uniform documentation can be done, and the same can be tendered as per the government mode for leasing out the space to be given to the public sector, to the private hospitals or the private labs. Similarly, hospitals on a PPP mode has also to be established, as it is clear today with today's formal speech of the Honorable Union Health Minister that the vision of our worthy Prime Minister for providing universal health coverage to whole of the country, strengthening of the public hospital has to be taken with more vigor in making the module for involvement of private sector by providing concessions, etc., in procurement of land, so that these hospitals are able to provide the healthcare services on the Ayushman Bharat packages to the beneficiaries and the general public. The EGEM, the initiative of Government of India
for procurement in government sector has already in place and is being highly appreciated, being me in duty. However, same need to be strengthened with regard to the availability of all items required in the health facility with uniform specification and regional distributors. This system will make health functionaries free to order the items required or required SOS without wasting time in the lengthy processes, and the regional distributors will be able to deliver in the shortest time period. We need to develop an exit interview for the beneficiaries so that every patient, after having been treated by the health facility, be made to record his issues which are required to be addressed by the health facility in charges. Thereby, the quality and delivery of healthcare will improve upon without any penal action thereof. The maintenance of separate accounts. The package amount payable to the health institutions on account of service rendered under Ayushman Bharat scheme are transferred in the Rogi Kalyan Samitis in most of the states and UTs. This need to be deliberated so that it can be deposited in a separate account, the powers of which should lie with the facility in charges, so that the procedural work involved in seeking money out of the RKS is very lengthy. So a systemic approach identifying the tool for strengthening of public hospital is the need of the hour. As an initial step, we can frame guidelines, draw actionable points, define mechanisms, and provide collective support to find out ways to strengthen public hospitals across the country. This small but firm step shall lead to a big leap in due course. Thank you.
So with this, I request Chair Mr. Pandey to the panel discussion. Dr. Ratan Kilkar, kindly.
Thank you, Dr. Arun. I think your presentation was quite elaborate on what the committee has thought and what is the way forward and what can be done. So here I think we need to hear probably from the states. They've already given their feedback to the working group here, based on which a very nice report has already been published. So I think more than the panel speaking, I would also like to involve the audience. Probably they also may have some good comments to offer on how do you strengthen public hospitals using PMJ. We all know for a fact that money is coming. How much of money has to be given, to what extent it has to be given, what are the kind of priorities every institution has to strengthen their setup to ensure the continuum of care. There are some good practices which has come about in Karnataka and other places. So how do we imbibe these good practices? How do we ensure that the rest of the states also follow a mechanism so that the money doesn't just land up in some particular hospital and just stay there? Some hospitals might be doing extreme good work, but we also need to understand that they are also funded by the state government. They are also funded by NHM. So there's a lot of money flowing, but the best utilization of the money to strengthen a particular hospital is what has to be prioritized. I think those are the things probably we could discuss in this group, and a lot of good practices have come. There's no one particular strategy to strengthen a hospital. Every state or every a particular place will have its own unique problems. Customized solution is what is needed. I think your document is very nicely drafted. When I went through it itself, it was very. It was very clear that a lot of work has already gone into it, and your way forward, everything is very clear. So probably we would may not have one particular formula to follow here. Every state may have to take a choice, but yes, they have to decide appropriately based on their local conditions. So this is what I think is needed for any strengthening to happen. But yes, one particular requirement is there should be a common decision that yes, we have to strengthen it because funds are flowing. How do we do it? Probably may have to be left to the state to decide, and based on the priorities, they may have a good a sense of what to do with this entire money or the fund that is coming in. So, with that remark, I would probably want to understand, or for the benefit of our audience here, understand the Karnataka way of functioning. Probably that will add a lot of value to the discussion. So I request Pankaj sir to just give some remarks on what Karnataka exactly is doing and how this can be probably replicated by other states.
Thank you, Dr. Ratan. Thank you, Dr. Arun. Actually, we had 2-3 rounds of discussion, and it was really good to learn what other states are also doing and to share our experiences. What I feel is, and it was felt uniformly by all of us, that the biggest challenge at the hospital level when the funds are flowing is to take a decision. And if that decision is questioned after 4 or 5 years, a decision which has been taken in good faith for the improvement of the hospital and for improving the facilities in that hospital for the patient, if that is questioned and the inquiries which are done on that decision, then that becomes the biggest stumbling block for any administrator or for any doctor who is there in the hospital. So I think we need to come out with the assurance to the public health institution, the administrative medical officer or the resident medical officer, that see, these are the guidelines, this is how it has to be done, and we are there to help you in improving the facility. Probably at the governance level or at the state level, we should come out with certain guidelines, which, for example, in Karnataka, what we have done is, if we give the independence to a hospital to fill the gap can be in 2 ways. Either it can be in the form of HR, you don't have specialists, you don't have lab technicians, you don't have nurses, or it can be in the form of equipments. You don't have certain specialized equipment. So you may have specialists for a particular branch or wing, but you don't have the equipment. And equipment again can be small or big equipment. So the challenge is, okay, we have the money now. I have got, say, for example, 50 lakhs with me in my hospital account. I need to purchase certain equipment which cost me around 10 lakh or 15 lakh. And I have got some manpower to hire. And what are the guidelines? So probably the state needs to facilitate this entire process of decision making. And what we have done in Karnataka is that we have the historical knowledge that these are the equipments which have got this price range. Gym is one thing. We would have been really happy, and probably all of us should push forward and should push and ask the gym that you please include a lot of medical equipments into the procurement. That will make the things much, much easier for us. But till the time it comes, probably every state has got a medical supplies corporation which has been procuring equipment that can become a kind of a base rate. That okay, these are the tech specs, these are the base rates. Over and above that, you can improve and give a price range, because obviously when you procure at the state level, you get the advantage of a good discount because of large numbers that you are procuring. So keep that point also into account, and then give a range that this is the thing. And then the specs. And if some hospital thinks that okay, no, the specs can be further improved, and they have got a committee, it can always ask for that. So that way, that confidence should be given to them that okay, this can be done. Then similarly, suppose you have got equipment which has come to the hospital, the specialist is not there, give them the independence and probably ask the public hospital that you hire at the same rate at which the private hospital is hiring. If you are asking for ortho surgeon, and in the private hospital, if the ortho is getting say 10,000 or 5,000 for a particular procedure, he will not come to your hospital if you pay him 2,000 or 3,000. So pay him 5,000, 10,000. You please notify these rates and tell them that okay, this is what we can do, and keep on reviewing it on. Obviously, it goes along with the regular review. Take the feedback from them. So this is what we did in Karnataka. Dr. Sajjan Shetty, who is here, Dr. Shastri, Ratan fortunately was there with us earlier. Now he is gone to Kerala. He was part of our health department's team in Karnataka. He was handling the NHM for the last 3 years, and he did tremendous work there. So we took the feedback from the field and we asked, what do you require? If we suppose you are made the CEO of this hospital, what improvements you would like to do? And then they started asking that we need this thing, we require this equipment, and we have got this problem that we can't procure so easily, and therefore give us the guidelines. So this is what we did, which gave a confidence to them that okay, we can improve on this, and we can, and the competition is with they see the competition with the private hospital. If the private hospital in the city is earning so much, why can't we earn? So that was the idea with which they moved.
So the success of Karnataka has been empowering the doctors who are generally considered bad administrators. But yes, they can deliver provided they are backed up by support from the state government. So that is one of the things which they have done, and involving them in decision making, assisting them to move forward and make their institution better. There are many institutions there who have done extremely well. I'm sure similar examples also are there elsewhere in the country. But yes, Dr. Sajjan Shetty is here from Karnataka. He was also instrumental in driving a lot of these things, especially in the northern part of Karnataka, which is supposed to be a backward in terms of the entire state. So he has also done extremely good work in that area as well. See, when we say backward, it's not that it can't be rectified. It's just that it needs some kind of a push and some kind of an assistance, like what Pankaj sir has just mentioned here. Probably we'll hear for a minute from Dr. Sajjan Shetty what could probably galvanize this entire thing. We have similar issues in other states, probably some backward places, some backward states and districts will also have similar issues. How do you motivate people to ensure these decisions are taken? Because incentivizing is one, but people will not want to take a decision of crores of rupees lying in their hospital. Even if there are guidelines, there will be somebody in the department who may say that don't do this, don't do that. You will get into a problem, your pension will be withheld, and these are the kind of things which doctors generally hear. So, Dr. Sajjan Shetty was one such doctor who has also delivered. So, let us hear for a minute what probably he has done to motivate his staff.
So, actually, after coming back from the medical college, after having worked as a lecturer in medicine in medical college for nearly 6 years, I went back to the most backward taluka of the most backward district, Gulbarga, in Karnataka, and I worked there for 11 years. So when I was working, there were only 2 doctors in the Taluka hospital, and we were handling all the cases, all types of cases, only 2 doctors we were managing. But the biggest constraint what I found while working in a Taluka hospital was mainly the support services. I think the support services needs to be, actually it should be outsourced. Like dormitory accommodation for the attenders and other facilities, because doctors are actually they are more burdened with these other non-medical things rather than the treatment aspects. I think doctors should, since we have deficiency of the specialists and the doctors, and they should be allowed to do only the medical work or professional work rather than attend to the non-medical work and the support services. I think the support services have to be outsourced, and the professionals have to be given the task of handling only the professional tasks. Okay. That is one thing, sir. Second thing is, I think we can link it up with the quality, since lot of now the infrastructure has improved in the Karnataka state. 20 years back, there was the hospital buildings were not good. Now the good hospitals have come. The HR, of course, there is still HR issue is there. But now we are in the process of improving the quality of services in the hospitals. I think some of our hospitals have already got the national certification under NQAS and Kayakalpa and Laksha. I think the incentivization, what we are providing, 30% incentives to our doctors, I think that can be leveraged with the linked with the quality. so that the person who is, it should motivate them to improve their quality and achieve the NQA standards and the Lakshya standards.
Motivation and role definition and giving clarity to their work will definitely improve.
That will, I think, further motivate the doctors.
Dr. Arun mentioned about the J&K initiative. If our friend is here, if he can just share his view.
I just heard him. It's fantastic.
Yeah, excellent.
Good evening, everybody. I'm pleased that I have been called to this working group to express my ideas that how we can reform healthcare. I still am of an opinion that 2/3 of India's population still have faith in public hospitals. And we will definitely have, because PMJAY has thrown more challenge before us, we will have to raise the standard of these public hospitals to a national and international level if we have to attract these golden card beneficiaries. Because they have been now empowered by the government of India. They know that they have 5 lakh rupees of money behind them where they can have the best healthcare. They can even fly to New Delhi from Kashmir or any other destination. So you will have to definitely improve the healthcare in your respective hospitals. And I am a firm believer that use of technology is one of the ways that you can make your hospital smart. And that's exactly what we have done in Pulwama. I think Pulwama is a word quite familiar with you, that is in Kashmir, southern Kashmir, which always remains basically in the news for so many other things. But in last 1.5 years, 2 years, we have changed that hospital. You won't even, I would invite you to come to my hospital. You would be surprised that the nurses who had been recruited some 30 years back, who had a qualification just 8th pass those days or 9th pass or still working in those hospitals, are working on laptops this time. They are the people who are discharging the certificate. They are giving discharge certificates in my hospitals. So I basically worked with them. I, in fact, had a lot of meetings with them telling them that you have to change the way of your working. And that's exactly, it has given us results. So in my hospital, from your admission to discharge, everything is handled through computers. Everywhere it's laptop, every section. Even if you have to get an OPD turn to any specialist OPD, your turn will be defined by the computer. Usually you, as an administrator, you get complaints that the hospital staff gets patients on their own, the queue is not properly maintained. So once you get the computer generated OPD turn for every specialty, for every OPD, and even the entry and the exit time is given by the computer, the itinerary of the patient, his whole stay in the hospital is monitored by the computers. So all the sections he visits, all the investigations he gets, then automatically get recorded in the computers. So it's the system that we have developed and evolved over the time. Then Dr. Deewan talked about the PPP more services. I will frankly tell you that we have adopted this in our hospital. This time I have a state-of-art biochemistry, immunology, tumor marker, and hormone laboratory established under PPP mode. I have just given them a 10 by 14 room, and all infrastructure has been given by the service provider. They belong to the latest generation analyzers, DICE 400 and Beckman Coulter, which even SKIMS does not have. I am telling you it with a lot of authenticity. So I have a 250 parameters of analyzer system, and we get these investigations and the government approved rates of J&K. And I would say you that it is again CMC Valor accredited. The laboratory in my hospital is controlled by the CMC Valor, yes. And the radiology department is by ARB. So we have a strict, stringent control measures also adopted by the hospital. It has basically brought in a lot of trust and faith in that hospital. And as a result of these things which we have adopted, infection control measures. I remember 3 years, 4 years back, we had 7, 8 maternal deaths in 2 years. And I, as an anesthetist, would talk to my medical superintendent then to find out the reasons for this maternal mortality. He would often say it's congestion, it is a lot of people getting into the hospital. But then we introduce small baby steps. We use the 7-day, 7-color bed sheets. Every day the bed sheet gets changed. Then we use hand sanitizers. We made the attendants to use the hand sanitizers before coming and getting out of the wards. And not a single death has happened since then. So small things have changed. We use formalin chambers, Sidex chambers everywhere. We are using formalin to clean the floors of the labor rooms, theaters, and other things. It has drastically brought down the infection control rates. And simultaneously, when we talk of sanitation, we outsource sanitation in my hospital. I asked this contractor to get the modernized, mechanized machines. We pay them from the Hospital Development Fund. I pay them around 1.3 lakh rupees every month. It is he who gives us 13, 14 manpower to run the sanitation of the whole hospital. But he has 10, 15 mechanized machines to do it. We don't use brooms. He gives us all those detergents and everything is included in that. It's part of the package. So as an administrator, I don't have to think routinely, go around and say, this is not there, this is missing in the store. So all that I have checked in the hospital. Second, about these PP mode services is the beauty is that you don't have to worry about AMC, CMC and so many other things because it's absolutely at the zero expenses by the government. You are just giving a space. The reagents, the machines, the manpower belongs to the service provider. And what's the beauty that out of the total revenue generated, suppose if the total revenue generated by this lab is 8 lakh rupees in a month, the 60% is given back to the hospital and the service provider takes only 40%.
So you have a good revenue sharing agreement.
Exactly. This is a unique thing that we have.
All the things that you mentioned in your hospital, is it done using the PMJ funds or is it?
We had started them, but PMJY has helped us further, and it has basically reposed the trust in the patients. There are a lot of other public hospitals in the vicinity, but PMJ patients prefer to visit my hospital, and that's the reason that I have almost done more than 650 PMJB cases in last 7 months or 8 months.
The revenue is being generated. This is a public hospital. Have you imposed service charges or what?
No, their government, suppose there's a lab, you're doing some lab investigation. The government rate is there. J&K government has a special rate for every package. So you're doing, suppose, LFT. So we charge you around 80 rupees. To the patient. Yeah, not PMJA. The ordinary patients have to pay. So out of those, the 60% of the revenue goes to the hospital. Absolutely. But I don't have to buy the reagents, I don't have to go for AMC, CMC, I don't have to buy the X-ray films. So all things I have managed in this kind of...
I have a question.
Please.
Under free diagnostic scheme, there's a list.
18 diagnostics.
Yeah. So you cannot charge.
Absolutely.
So LFT is absolutely covered under that. So once the PMJAY
in LFT only serum bilirubin is covered, not all
so
elements.
So you're basically leaving out the serum bilirubin and the rest you're making the charges.
Under free diagnostics we do absolutely free.
Okay.
But then the NHM people have to pay for the free diagnostics to the hospital.
See,
the NHM have to pay.
What I heard of Dr. Pandey and of Dr. Ratan, I was really wondering that there are so many structures that we have. There are different guidelines which we have for NHM. There are different guidelines which we have for our state. There are different guidelines we have for our SHA. And all the schemes have their own limited flexibilities which we are given. Now, if I talk of NHM, I know that I have to take the permission from NHM GUI. If I'm talking of state, I have to take from the state. Now, when we are talking of SHA, it sounds to be a very good framework that yes, we can go in for outsourcing of manpower. I can go in for the outsourcing of services or whatever. But in the end, there has to be a ceiling somewhere. So where is that ceiling?
So the conversion should happen at the state and the district where this is in operation. The state has to lay out those guidelines. That is what is one of the recommendations as well. Lay out guidelines for various things. What is the funding which can come through the state? You identify that. For what purpose you identified? What can happen through this PMJY? You need to identify it. What can happen through the NHM? All this has to be, you need to have a blueprint at the level so that it becomes easier. That is where all these guidelines, everything will come, help. For example, he is doing a PPP model. So if he's doing a PPP model, he should be aware of what is the funding he's getting from NHM, from the state, and what can happen here, so that it will be a comprehensive whole rather than in bits. So at the level of the facility, it's not much of a confusion because this very clearly told to them what they have to do. So we need to address it that way. I think extremely good work has happened in J&K. But doctor, my only worry is when you're speaking, it shows that you're very passionate and all that. Probably, is it happening because you are there, or is it going to continue? Post.
And that is what everybody is saying. But I personally believe once you build up a system, whosoever will come next will have more challenges. Suppose the PMJY of last 1 year, you are discussing how to take it further.
Right.
So you cannot take it back. So I personally feel there is always a way forward, and if it's a way backward, the person who will try to bring it down or denigrate will be absolutely removed next day only.
Right.
Because then the people also have the expectations, they have that kind of a trust in that system.
So looks like what's coming is every state has its own mechanism to handle the funds based on the requirements. They're trying to do something, and
I just wanted to comment on that. Actually, I am Professor Talukdar. I am from Guwahati Medical College. Ours is a very large tertiary care hospital. We have 2,200 plus beds, and we have more than 90,000 admissions in a year. But basically, this is something to do with the guidelines that Mr. Pandey was talking about. Because, we have, like what you say, most of these services we have already outsourced. We got everything, cleaning, sanitation, everything is there. It's taken care of. And although what you were saying on guidelines, there's recurrent expenditures, like hiring personnel on that. They are really very huge. Actually, we have a lot of needs, like lab techs and all that. We have a lot. But, this is recurrent expenditure. Suppose we cannot appoint people for just specific for PMJY for only those things. So these issues the government will have to actually, because public has they have to take care. My only issue is just filling the gaps in service. Now, I will just say I have some money because we are a tertiary care hospital. We have need of, say, machines because of costly machines and all that. My issue is like what Mr. Pandey was saying. How to buy it, how to do that, because there are no definite guidelines. Now, if I buy, we all know as a doctor, we all know which machine is good. We can buy it in the private sector at a much lower cost than contrary to what you all are saying. If I buy it from the government service, this is far more expensive than what you can buy from the government in the market. Strangely, I don't want to go into that, but this price is generally twice, thrice than what the machines in every private hospital is going to buy. So, if there are no, I can buy it, but then again the question of following financial guidelines and everything comes. Because if it is in the approved list of the government, I have no problem, I can straight away buy it. But most of the things are not in approved list. Now, you have to wait a long time for a machine to come into approved list. You all know in the government service. Now, critical things like suppose a machine in the ICU goes bad, we need it immediately to continue the services on that. And I can easily buy it because I have some money. And we had that money because, now how to buy it? Because there are no clear guidelines. Financial rule again say I have to float something, get tenders or quotations from this, that. If we make it clear, then our services will be much better.
No, these issues exist throughout the country. It's not only in one particular setup, Suddenly X-ray machine, the wire could go wrong, there could be some problem.
C-arm goes, the OT is shut down.
I think there is a national level regulatory mechanism now which has been recently launched for all equipments.
What generally happens is we just think only for that particular moment. We need to plan for a longer period of time. Even in a tender, if you're buying something, you can always have a warranty or replacement components in the tender, which will probably help you. And in case you say there is something very urgent, you can't wait for a tender, they can see with the concurrence of your finance department, government, you can always come out with set of guidelines to purchase, but you have to justify that purchase. Those kind of things have to happen in the system. Only otherwise, like what was Servos saying, everybody will be in a problem after you do something for.
Yes, that's right. Because this is a good chance for us to improve the services without spending time for it. That's it. If we have just something right now, it gives the director or the principal or the superintendent of the hospital authority to do it. And of course, we'll have an in-house committee because we'll follow it. We'll have an in-house committee will select and we'll place the order. If that kind of guideline goes from this group, I think in the end we'll all benefit.
I completely agree. In fact, one step forward can be that GEM can be asked to have as many medical equipments as possible into their portal because they are.
It doesn't have much now, sir.
They don't have much. That is the biggest challenge. So,
yes, sir.
As chairperson for my medical supplies corporation, which procures a lot of equipments, a lot of our tenders run into single bids. And then we were looking at GEM that, okay, whether they have got a similar equipment, and we found that they don't have equipment. So probably one strong recommendation can go that GEM should have as many medical equipments as possible.
So we can recommend, and this is an invitation from GEM side. Yeah. I actually approached GEM for this. So let us help them. But they are actually not able to finalize the specifications,
exactly.
And they are finding themselves at sea how to go about it. So if you can, Dr. Talukdar, if you can provide some help to us,
yes, sir.
To some dedicated help for 10 days per speciality, then we can actually get it on board very fast.
Yeah. Okay. Actually, I have a suggestion that some of the states, Medical Supplies Corporation, they keep on procuring and specs are there.
That will
you can have a common spec and the institutes of national importance and all that they are procuring, so that we can come to a common meeting ground that these are the specs which are bare minimum, which are the best. That way we can do that.
Yeah, so I was busy in this revision of rates. So after this, I intended to take it up with AIMS. But I will request Dr. Talukdar also to please pitch in, because GEM people are actually after us, after NHA, you please help us with these specifications and all these things. So it will be actually good. So we will get in touch with on this, and we will actually get it done practically.
I also see that Tripura has also participated in the group. Is there anybody from Tripura? Probably we can hear if they've done anything different, or something which we could learn. May not be here today. So I think some very good work has happened in this, the group 5. I think it's nicely drafted, whatever has come, and we've had a reasonably good, healthy discussion today as well. So I think coming from each and every one of you, what has to happen should happen in that particular state based on the customized requirements. So they need to plan properly to utilize these funds. Some could be a facility may need a HR, some may need some instrument, equipment, or whatever. But making use of this fund to the maximum extent possible, more efficiently, is the need of the hour, because a lot of funds coming in. So we need to plan properly, and also, like what was discussed, we need to also ensure what are the other sources of funding coming in, so that there's no overlap, there's proper planning. So I think this group has done extremely well in terms of listing out the way forward as well. I think, with that, we could, I would like to probably wind up this discussion, and thank you for everybody, thanks for everyone for participating in this, and thanks for NHA, especially Dr. Arun and team who have been working quite tirelessly to make this happen. I think it's very nicely done. Thank you.
Thank you. Can we skip question and answer? I think we have done the question and answers. So I request Mr. Pankaj Pandey to actually give the concluding remarks.
Thank you, Dr. Arun. In fact, it has been a good experience of working with this working group 5. And rightly said, we had rounds of manthans. And what has come out should be the nectar for the public health institution. It should revive them, regenerate them, and they should become much more stronger. So we hope this working group gets the nectar or the amrit for the public hospitals or public health institutions. Very important points have been raised, and I think every state has its own solution. They can do that. I think the structure is very clear. The NHM and the state government gives you the basic funding for the infrastructure and all that, including the staff. PMJY and the user charges will help you in filling the gap. The smaller gaps, which many times bother you a lot. The gaps may be small, but the headache is huge. Your water tap or the water supply is not functioning, the electricity generator is not functioning because something has gone wrong. And I think in the NHM they have come out with the biomedical equipment system, a management system which takes care of all the biomedical equipments which are there in the hospital on a long-term management, and where the written down value of the equipments, the operator takes, and that is there in most of the states now, and a lot of states have done that. So if the doctor or the hospital
has comfort from the point of view of maintaining all these things. That, okay, you have got someone who will take care of the biomedical equipment, 12 hours, 24 hours, it will get repaired. You have got someone who will take care of small electronics or civil work and all that. Then, and all this comes from the funding of PMJY and the user charges. And the PMJY is a substantial funding. Now it depends on the state what kind of share they will like to give it to the public health institutions. Some states have decided, okay, we'll pass on the 100% to them. Some states have decided that, okay, no, we should have an incremental kind of a system where we say that, okay, the institutes of excellence, which, and they are autonomous in most of the cases, should be passed on the 100%. The institutes whom we support through budgetary mechanism, like the public health centers and the block level hospitals, will pass on a little part, but it depends on the state, what kind of priority they want to give. And then again, how do you incentivize the staff who are working in the government health institution, public health institution, and I believe today, and the confidence of the public in the government institution, I'll say, has increased because they have seen the overcharging or extra charging and unnecessary running around in the private institutions. Even if someone goes in a private institution, the running around which they have to do an unnecessary diagnostic which happens. So it again brings the person back to the public health institution, and probably we need to make them so strong that we repose that confidence which was there earlier, and then we provide a better care to our patients. Very good work has been done in Pulwama. I will like to congratulate and commend on the very good work. And thank you. The debate of a separate account for the PMJY fund which is flowing is obviously there, and probably we need to make it much easier so that Rogi Kalyan Samiti, because now what I in Karnataka have seen is now 80% of fund which comes to 90% is from the PMJY, not from the user charges, because user charges are now negligible because most of your diagnostic free drug scheme and all that, so you don't get user charges unless until it's a tertiary care hospital where user charges will be there, and therefore we need to really make it very easy for the hospital to spend the amount and do the small works much easier. In fact, one thing which we are experimenting, I just wanted to share my experience with you. We are trying to experiment with a civil and electrical work maintenance thing, where all the 2,000, 3,000 items in a hospital will be listed. Whether it's a fan, the whole fan may go, or the small condenser which is there in the fan, capacitor which is there in the fan may go, one of the blades may go. So similarly, you divide all the components into various things, and then you come out with a comprehensive maintenance thing, so that an agency is there with you which will take care of this maintenance for the next 2 years, 3 years. So you have a long-term contract. So if some plaster is chipping off, you need not to work with in that kind of environment, and therefore you need to repair it, and therefore there should be an agency which in 2 days or 3 days should be able to do that job. So we are trying to experiment with this rate contract kind of a thing, where you have a rate contract for every material or for every work which you need to do in a public health institution, and probably that will then take the mind off the unnecessary thing, and the doctor will be able to concentrate on the real delivery of the services. So these are the various things, and I think a lot of things which probably the private sector can manage much better should be on a PPP mode, and we have seen that the PPP modes are working quite well in the case of dialysis, in the case of the various equipment, CT scan, MRI, bioanalyzer, and all those things, and in a profit sharing model with that, you will even work better for this thing. So I think it's a good thing, but again, in the PPP model, we have to take care of regular evaluation and then see that it doesn't result into a common man or a patient spending more than. It should not increase his out-of-pocket expenditure. So keeping those things in mind, I think it's a golden opportunity for all of us working in the government sector to strengthen our public health institution, to make them stronger, and carry out procedures, operations, carry out care, and continue the care for all the people who come to public health institution, and increase our share of punya. I always call it, all of us have got that account, and that account should keep on increasing. So increase our share of punya and keep on giving service to the needy. So thank you very much, and it's always pleasure to be part of such a working group, and I like to thank NHA, Dr. Arun, and all those. It was really good to interact with you in the various sessions. Thank you very much.
So, thank you, Mr. Pankaj. And what is the road ahead for this working group is, so I think we are all in general agreement with the report which has been drafted. There are few things which need to be added. Like the group seems to be feeling very strongly about that we should direct the state governments to come out with the guidelines and empower the hospitals to utilize the money. So let us include that in the report and in the presentation also. Let us do that. Then there is Mr. Pandey, I was hoping you will mention it, but actually TMH reminded me this. They have actually, through a tender, they have selected a third party which is managing all their claims with different agencies, different insurance agencies, with NHA. So what has happened is they have become expert. They now know every kind of claim that they are raising. So
yeah, we are also doing the same thing. Tata Memorial Hospital, that one private party has been engaged in our institute, because our Dr. B. Borua Cancer Institute is also a unit of Tata Memorial Hospital under Department of Atomic Energy. There are one such institution is Homi Bhabha Cancer Hospital in Banaras, one is in the Dr. B. Borua Cancer Institute Guwahati, and the Tata Memorial Hospital. We have engaged the same party in the same terms and conditions to all the TMC centers in the country, and that is why, though we are at Dr. B. Borua Cancer Institute are treating only one disease, so pre-authorization in terms of the entire state of Assam, ours is the highest. In the state of Assam. This is because of this professional agency being involved.
So yeah, TMH.
One comment. Yeah, it's very good to have a professional agency. In Karnataka, what we have done is we have put our local youth as claim executives. So these guys are being trained by the state health agency, and they are claim executives. So, but again, it depends. If it's a big institution, then you need to have a professional agency to be in place.
So we have 63, but we're still not. I have 63 ergometers, but I am not at all happy with it. And in fact, I was discussing with that to employ the same group in my hospital.
So yeah, I have one more point.
Arogya Manthan different. So what TMH has told us is just in the parallel session that their claim success ratio is 99.5. And that seems to be really impressive. So maybe we include that also. Then Pulwama, everyone is impressed by.
So I have one more suggestion, last one I'll give. I would like to say this August gathering that trauma and acute medical emergencies, what we say non-communicable disease, biggest epidemic before the nation. And in this context, our ex-Director General, Dr. Salimur Rahman, had passionately worked in Kashmir, and he brought up a skills and simulation lab in an area close to Gulmarg. If any one of you visit us, it was the first of its type of simulation lab, which was imported from US, which had a SimMan, SimMom, and Megacode Collie, wherein we have trained paramedics, nurses, and doctors on acute medical emergencies. So you would see in our hospitals in trauma management, and especially because of the conflict, we even get pellet injuries, firearm injuries. So you would see our paramedics and medical officers intubating those patients. And it has really helped us in decreasing that mortality and morbidity. And I personally feel all states should adopt that kind of a lab. It really helps. It really helps.
So we can perhaps include training also as one of the way in which this fund can be used for the paramedics.
patient.
Exactly.
Okay. And then Dr. Shastri had mentioned about Acha. Okay, I got the name wrong. Sorry. Okay. Then support services outsourcing was mentioned. So this has been covered. So maybe we will have a relook if it needs to be brought out more granularity. Then we will do that. Otherwise, I think it is covered. So these are the things that we will make changes. So if the group agrees, so these changes will be made and it will be mailed to you before submitting it to the CEO of NHA. And for tomorrow, you will have to actually present to the Honorable Health Minister this. So some of these changes will be made in the presentation. Okay. So I thank everyone on behalf of NHA, and it has been really fruitful, and it has been a learning experience for every one of us, I hope. And let us hope that we are actually improve our public hospitals through ABPMJ. Thank you.
Thank you very much. Thank you.
Thank you.